Good morning, ladies and gentlemen. Welcome back to the 6th International Conference and Exhibition of the Indonesian Medical Education and Research Institute. A warm welcome to you at the 6th Eyes on IMERI second day. This is the hobby, and I would also like to say gratitude for all speakers who join us today. My name is Sukma, and I will be the master of ceremony today. Thank you for attending the whole day, and today we will have 4 excellent topics from our distinguished speakers. I hope you all are now getting more excited to start our session. And this session will be moderated by Dr. Isabella Kurnialim M. Biomed, PhD, PA. Dr. Isabella finished her medical doctor in Universitas 11 Maret in 1998. Then in 2003, she finished her Magister program in Biomedical Science, Universitas Indonesia, and then finished her PhD in Hiroshima University, Japan in 2009. Now she is currently the head of Museum, IMERI FK UI, and lecturer at Anatomy Department, Faculty of Medicine, Universitas Indonesia. Please welcome Dr. Isabella Kurnialim, M. Biomed, PhD, PA.
Good morning. Thank you very much, Dr. Sukma Dewi, for information about this morning event in Hall Bay. Okay, I greet to all the speakers, Dr. Radiana, Dr. Yudan, Prof. Rino, and all the participants today. So today we will have a very nice presentations in the topic of inventing stem cells hepatic intuitive apparatus of end-stage liver disease. And today I will be the moderators, and all 3 speakers will be present their a nice topic in 20 minutes. We will continue first with Dr. Yudan Wulanza presentation. Dr. Yudan Wulanza, STMSc PhD, graduated from Chemical Engineering, Gadjah Mada University in 2000, and then continue his master program in Mechanical Engineering, Asian University. And then he also graduated from a doctoral program in Robotics and Bioengineering, Università in Pisa. And now his current position is an associate professor at the Department of Mechanical Engineering, Universitas Indonesia, and also the researchers at the Research Center of Biomedical Engineering, Universitas Indonesia. Dr. Yudan Wulanza, the time is yours.
Thank you very much for very nice presentations, Dr. Bella, and good morning, everyone. Well, I already pre-recorded my files. Is it possible for the committee, or should I?
Yes, Dr. Yudan. Thank you very much.
Thank you very much. Good morning, everyone. It's an honor for being here today. Of course, I would like to thank for the Committee of Eyes on IMERI, the 6th. My name is Yudan Wulanza. I came from the Department of Mechanical Engineering, Research Center for Biomedical Engineering. And I also work very closely with the group of SCTE, Stem Cell Tissue Engineering Research Center, from the IMERI Universitas Indonesia. So my title today that I would like to discuss is biofabrications on towards 3D cell constructs to induce stem cell differentiations. And this is how the outline for today is that we will discuss the brief of tissue engineering framework, and moving on the scaffolds from, and also the 2D to 3D cell cultures, which became the birth of bioprinting. And we will see how the fabrications as we know today, and also the future trends. This is the bioengineering strategies, how improving cell viability of engineered human mesenchymal stem cells. We could see that bioprinting is only one of them among the other factors, such as the biomimetic scaffolds, protein signaling, and etc. Again, the keyword here is that we are working in the bioengineering area. So, of course, there will be more approach in the other area. We know that the first strategy is in the scaffold engineering that allow us to mimic the extracellular matrix as the comfort home for the seeded cells. And in brief, we knew that tissue engineering pillars, which involve the scaffolds, the cells, and the protein signals. Here, we also see how the engineered environment that so-called bioreactors believe to be able increasing the cell viability as well. And this is one example of the scaffold as we know today. Normally, it has four structures and made of the degradable materials. And this is how we fabricate scaffold nowadays using the additive manufacturing technique that enable us to control the geometry, the structures, and also determine the material as we wanted. However, as we speak, scaffold is only one pillar in the tissue engineering. It means that we need other efforts or technology in order to control the cell growth. This is so. Let's move on the 3D cell culture technologies in brief. This is what we call as microenvironment that encourage the cell to be induced to be viable. This environment was driven by three stimulations. To be short, the physical chemicals, mechanostructures, and the biochemical pathways. Shortly, we are working with many parameters to optimize the cell viability. And aiming the 3D structures for three-dimensional cell cultures, these techniques includes several technologies such as the liquid overlay, the hydrogel embeddings, the flash bioreactors, and also the 3D bioprinting. So we start to go on the bioprinting techniques here. And by combining the two, the scaffold and the bioreactors, we might get better chance to culture the cells, to control them, and to improve them. Let's replicate the human body condition better. And the bioreactor also could be arranged to allow us to monitor them directly on our optical tools, gain the information, and observe the cells under our eyes. And we had known previously that the scaffolds helps the cell to stabilize in the substrates and grows. But we had been also aware that there is other ideas, so-called scaffold-free during the cell cultures, which also sometimes also called as bottom-up approach. And let's see between these two, the top-down approach and the bottom-up approach. At this moment, it's hard to tell which approach gives the best results or the correct one, since there are many parameters that are play in field of the bioengineering as we known before. At this moment, we refer them as the top-down, which start with the physical structures. In this case, it's the scaffolds, whereas the bottom-up approach was starting with the cell itself, encourage them to assemble and form tissues and organs at the end. And this is the combining of these two approach. This non-scaffold ideas is transforming from 2D to 3D, which later as called as the bioprinting. And the global 3D cell culture market that anticipates the growth of this market between 2000 and 2023. So let's see how the bioprinting technique originally and what are the basic principle behind these techniques. And of course, the bioprinting was trademarked because of its bioinks, which it has the cell insides, and then deposit the ink into the substrates, liquids, and then the ink is solidified with certain arrangement. The pattern of the ink is programmed. So this is the three main mechanisms of depositing the ink. The first one is the laser or light aided. The second one is the inkjet. And the third one is the method of dispensing the liquid or the bioinks into substrates. And the basic features of the bioink is that we are able to control the solidifications of the bioink that it is possible by cross-linker agents. And there are so many mechanisms on controlling the mechanism of the cross-linker. For one is by exposing them with the heat, with the light, or with the difference of the concentrations. And this is our homemade bioprinters, which was prepared to direct cell printings. And at this moment, we have seen the 2D structures there with the dimensions and the predetermined program as the image. So let's see a small video on that. So this one is basically working as the third mechanisms, which was the dispensing the liquid using the piston movement. Yeah, I hope that it could seen better from your screen. So let's continue. And yeah, what we've seen in the previous image is that we've been succeed with the 2D structures, and at this moment we would like to working to stacking them into realizing the 3D structures. And this is the applications in organ printings that we are able to program the paths of the inks and setting the solidifications on the support materials. And in this case, the support materials is the liquids. And in that case, we would like to realize the microstructures in the micro environment as we wanted. So we could see that the biofabrications is, in short, is the printing process together with the engineering of the selection of materials to realize the constructs in the predetermined construction. This is the issues on the bioink materials, and that mostly at this moment we are working in the hydrogel and the hydrogen and gelatin materials. The materials is sometimes also combined between two or more other substances. The outlines of the tissues and organ print engineering based on the biodesigns, biofabrication processes are performed using the biological materials, including the living cells here, which next, the fabricated products are incubated during the bioprocessing stage. The desired results is that biological tissues or finally organs that shall be manufactured through the engineering approach. So that will be the definitions of the biofabrications since the 2010s. And this is the current results that constructs the 3D and the various size from millimeters into the micrometers. And this is the state of the art of the commercial parts on the organ printings that we know, that so-called the organophore company. They claim that they are working on the organ printings. If we check on their websites, they have been worked in human liver tissue since the 2010s. And yeah, if we see the company, it has been in the stocks. Well, actually, this is not the indications, or it is not our justification to say that this company is good or not. But however, we see that the trend of biotechnology is about to come in this area. So as the conclusions for today is that we see the resumming the biofabrications is that the requirements to be succeed in this technology is, of course, successfully manufacture biological tissues and the organs. But as we know, that there will be so many factors that affecting on this direct cell positioning technology, such as the microstructures, and then we might working with the multi-cell types. Realizing the 3D structures will be the one of the issues, and of course the vascularizations. And as a conclusion, 3D bioprinting allows the spatial controlled placement of the cells in a defined 3D microenvironments, which then the bioinks are formed by combining the cells and the various biocompatible materials, which are subsequently will be printed in the specific shapes to generate the tissue-like, and in this case is 3D structures. And that will be all. And I put some a list of definition if you would like to oversee how we define several terms which I forgot to mention before, and some references which we took from other works or even our works. So that will be all. Thanks for the opportunity, and I give the time back to the chairman. Thank you very much. Very good morning.
Thank you very much. Thank you very much for the nice presentation from Dr. Yudan. So let us now continue to the second presentation that is from Dr. Radiana Dewayani Antarianto, MBiomed PhD. I will inform the CV of Dr. Radiana first. She is graduated from Medical Doctors, Universitas Indonesia, and she continued the master program in Biomedical Science, Universitas Indonesia, and finally, she graduated as a PhD in Regenerative Science, Hanover Biomedical Research School in 2014. And now she is working as a lecturer at Histology Department, Faculty of Medicine, Universitas Indonesia, and also as a researcher in the Stem Cell and Tissue Engineering Research Center, IMERI, FMUI. Dr. Radiana, the time is yours. Please, the committee share the presentation.
Yes, can you share the PPT first?
Yes.
Okay, thank you so much. Okay, play slide, thank you. All right, so SHINTA is abbreviation from Stem Cell Hepatic Intuitive Apparatus. It is a bioartificial liver that was intended for liver failure patients, chronic liver failure patients in remote areas who does not have access to liver transplantation procedures, which in Indonesia, there are currently only 2 hospitals who can provide service for liver transplantation. So this is intended for bridge therapy for those patients. Next slide, please. So where are we now? Can you play the video? Can you play the video? It's a video there. Yeah. Yes. So as you are currently watching, this is where we are now. This is 2 days ago in IMERI. The vessel, the millibioreactor vessel that you see in the center comprises of a very microstructure liver tissue where we differentiated the hepatocytes from induced pluripotent stem cells. The second compartment, where you see kind of like a blood bag, it's filled with medium to maintain the viability of these hepatocytes. And there are other electrical components there where you see that's the perfusion pump. It's to generate circulation of the medium to keep the hepatocytes alive in the millibioreactor. So that is where we are at the moment. Where we are going next, next slide, please. Okay, so this is where we are going next. We notice that bioreactors have, or bioartificial livers have exist for quite some time now in very sophisticated advanced medical centers across the world. In America, in Germany, in China, you can find it. The problem with those bioartificial livers are that they are static, they are immobilized, quite large, the bioartificial liver, and therefore the patient should come to the facilities, which is abroad, not in Indonesia, to obtain those services. While liver failure patients are practically, they have been hampered with chronic conditions that will not enable them to travel so far. So where we are going is that we will develop or design these compartments in a very compact manner. Engineers will help us. Pak Yudan is also in this team, where all of those compartments, the perfusion pump compartments, the millibioreactor compartments, and the compartments for circulation of the medium will be placed on a belt. And this belt can be dislodged, or you can just take it off if you don't use the dialysis or this bioartificial liver. So this can be a bridge therapy for the patients in remote area. They will have an ambulatory or mobile bioartificial liver to help them improve their quality of life. They can visit their hepatologist once every month, also to consult about their bioartificial liver. Okay, so from 2021, this is where we are at the moment. We are currently testing in vitro of all the compartments that I've showed you previously in the previous slide. And at 2022, that will be the first in human trial. The clinicians will take over the project from then on. And in 2022, early 2022, I think we also would like to test it in vivo in an animal model of bile ligation ductal model. And this will be done with a colleague from Bogor Agricultural Institute. Okay, next is in 2023 is the upscaling of Shinta. In 2024, we hope that this will be on the market for all the Indonesian patients, and stem cell and tissue engineering cluster IMERI will still serve as the core facility or core lab for the further advancement of this bioartificial liver. Next slide. So this is who we are. I'm very blessed to be representing this team. Actually, the leader currently all the one that's overseeing the experiments are clinicians coming from Division of Vascular Surgery, Dr. Ahmadu Muradi, and coming from Professor Rino's Division of Hepatobiliary Internal Medicine, Cipto Mangunkusumo Hospital, Dr. Cynthia Olivia Marwinja Sirwan. She's actually the core inspiration. She always asks a very critical question that make us think, make biomedical researcher think. And the one that will provide the technology, the microstructure of the liver is Stem Cell and Tissue Engineering Cluster IMERI with me and the researcher, the young researcher who produced this microstructure liver is Adrian Pragiwaksana. And we have engineers. The engineers is Dr. Yudan Wulanza, Mr. Muhammad Nadif, and a very young engineers coming on board as well, Muhammad Irshad. Next, if we will test this into the animal model, it's Dr. Fetniza Yuwantito. Okay, so that is where we are and where we will be going. So how do we get into this state? We get into this state by building brick by brick the capacity to develop or to produce the microstructure of the liver. Starting in 2015 with 2 master students where we co-culture in 3-dimensional methods using hanging drop methods, stem cells deriving from bone marrow and from umbilical cord blood CD34 hematopoietic stem cells, and which ask the question how these microstructures can modulate liver fibrosis. What is the mechanism? I will show you the result in the next slide. In the next phase, not yet. In the next phase, we have an idea to develop liver microstructure outside of the body. And we think we have to consider several options. First of all, the hepatocyte source option. So we directly program skin fibroblasts into hepatocyte. The term that we use is induced hepatocyte or direct reprogramming of fibroblasts. And the second one is that we also use the technique to 3D co-culture hepatocytes, since we know that hepatocytes also reside in the liver with other cellular components, non-parenchymal cells. So we develop as well a liver organoid. And since our liver organoid initially does not have a spatial distribution, they are clustered together as cell aggregates. There are several functions that cannot be used, which is biliary drain. So we use scaffold for that matter. And we develop liver scaffold, native liver scaffold, where we then continued this process by differentiating hepatocytes in liver scaffold and making this liver tissue engineering. As you notice, in the Milli bioreactor, the microstructure is coming from this liver tissue engineering construct. Okay, so next is the Shinta project. Next slide, please. Okay, so this is what we've learned so far, that we can develop a 3D microstructure of the liver using hanging drop methods. And if you would like to know more about it, you can read. This is available in Google eBooks, okay, how we obtain those 3D co-culture of the liver. Next slide. Okay, so this is something that a clinician can use autologously. So if we take fibroblast skin from the liver patients and then convert those cells into hepatocyte, this is an autologous hepatocyte, then we can directly transplant it into patients. This has been patented and the patent has been granted. Next slide. So in April 2021, we have patented this protocol. The protocol is also in the process of publications. Okay, next slide, please. Okay, so regarding the scaffold, this methods is very simple and it can be applied to all the remote laboratories in Indonesia. All you need is a syringe, 1 milliliter of syringe, and SDS, which is a detergent solution, okay, in several concentration. So with our multiple syringe injection methods, we can obtain a translucent native liver scaffold. Next slide. So this is our recent publication in 2021, where the characterization of using scanning electron microscopy have showed the intactness of the collagen fiber, the reticular fiber of the native liver. And we also have investigate the presence of fibronectin and collagen type 3 in this scaffold. Okay, next slide. So this is upcoming publication. It has been accepted at the 5th of October. So we differentiate hepatocytes from 2 types of stem cells, induced pluripotent stem cells and mesenchymal stem cells. And these are the result. Next slide. Okay, this is our methods. So we differentiate the iPSC and MSC into hepatocytes in 21 days. This is the overline of the experiments. Next slide. And this is how we do it. So initially, to develop this liver microstructure, we don't need bioperfusion or bioreactors. We use manual medium change to induce the cells, the stem cells, into hepatocytes, as shown here. Next slide. And these are the medium, the change of medium, how we obtain the basal and the cytokines and the small molecules to initiate the differentiation of hepatocytes. Next slide. And these are the results. So it's quite abundant and a lot of histological analysis here. But what I want to show you is that between the iPSC differentiated into hepatocyte and mesenchymal stem cells that differentiated into hepatocyte, there are several characteristics. From day 7 to day 21, despite the minimal amount of cells adhere to the native liver scaffold, they remain in the scaffold for 21 days. Okay, and more cells are adhered to the scaffold from the hepatocyte differentiated from MSC compared to the iPSC. Next slide.
I'm sorry, Dr. Nana, the time is up.
Yes, can you allow me for several more slides? I think this is still 15 minutes, Dr. Bella, in my watch. Okay, so this is scanning electron microscopy, showing you the hepatocytes differentiated iPSC from day 7 into day 21. As you notice, they are still holding on to the native liver scaffold. They have a different spatial distribution. In iPSC-derived hepatocyte, they are solitary cells, while in MSC-derived hepatocytes, you can find clusters of cells in those native liver tissue. Next slide. So if we look at several hepatocyte markers, such as albumin, apparently the hepatocyte differentiated from MSC are much more in line to the differentiation process, where the albumin is higher. And next slide. Also the cytochrome P450, which is the marker for functioning hepatocytes, also higher in day 21 in comparison to day 7. This is a check at the tissue level as well as at the molecular level. Next slide. However, if we look at the maturation profile, we check the expression of cytokeratin 19, and the cytokeratin 19 at the molecular level, there is a decrease, and the decrease is much more prominent from the hepatocyte differentiated by iPSC in comparison to MSC. This gives an idea that the hepatocyte differentiated from iPSC is much more mature in comparison to hepatocyte derived from MSCs. And we also see here, these are positive expression for hepatocyte nuclear factor for A, as well as for CEBPA. Those two transcription factors are prominent regulators in hepatocytes maturation. Next slide. So as a conclusion from our recent upcoming publication, is that hepatocyte differentiated iPSC in the Solari's liver scaffold, the differentiation is mature, much more mature. However, they have a lower cell to ECM adhesion, they have a lower spatial cell distribution, and lower albumin and CYP450 expression. We are considering this limitation due to using a single iPSC cell density, which we only seeded 35,000 iPSC per scaffold. Currently in our SINTA project, we use a higher number, like 5-fold the time for iPSC cell seeding density. We started with 150,000 up to 1 million cells per scaffold. So that is what we saw in the first slide. Next slide. So I would like to thank you, the committee. Thank you, Dr. Bella. Sorry for the extension of minutes. And I also would like to encourage you to look at our poster, ID number 29,500, which is the initial result from our iPSC-based liver organoids. Thank you all.
Thank you, Dr. Radiana. Thank you for the presentation that has opened our horizons, that at the IMERI has developed future technology in the field of the stem cells. And this is our hope for the liver disease therapy in the future, Dr. Nana. Thank you for the brilliant works, and congratulate to all the team. And next, now we will continue to the third presentation, that is from Professor Dr. Rino Alvanigani, internist, SPPD KGEH. He graduated from Medical Doctors, Universitas Indonesia, and then after that continue in specialization in internal medicine, also in Universitas Indonesia. And then he took the doctoral program in medical virology in Jichi Medical School of Japan. And also now he is a consultant in hepatology, gastroenterology, hepatology in RSCM and FMUI. And now current position is now in as a secretary Indonesian Society of Internal Medicine, and also a secretary of Indonesian Association for the study of liver. So Professor Dr. Rino, the time is yours.
Thank you, moderators. My task today is to bring you the clinical point of view on the use of stem cells therapy in liver disease. Let me share screen first. Is it okay? Can you see my slide?
Yes, Prof.
Okay, thank you. So the title is Stem Cell Therapy for End-Stage Liver Disease. Where are we now? We know that one of the problem in clinics is the end-stage liver disease. And this is my outline of presentation. First, we will discuss the definition and burden of end-stage liver disease, and then treatment modalities of end-stage liver disease, progression of stem cell therapy in the world, and stem cell therapy in Indonesia. End-stage liver disease characterized by deterioration of liver function and a subsequent high mortality rate. And this is, among others, is the liver cirrhosis. And patients with liver cirrhosis tend to progress to end-stage liver disease. And if these patients hospitalized in the intensive care unit, they will have a high mortality rate, about 40 to 80%. Our experience in Rumah Sakit Cipto Mangunkusumo showed that almost 50% of patients come to our hospital with already decompensated liver function. That is Child B and Child C. And this is not good because our study showed that patients with Child B and Child C have a mortality of more than 50% in 2 years. So this kind of patients should have more intervention and also more clinical management in terms of management of the end-stage liver disease. Of course, many countries have different conditions, but as you see, you can see that in many countries, the decompensated liver disease is one of the major problems in the hospital. So why is this? Because mostly the liver disease is asymptomatic, so they come to hospital already in the late phase of the liver disease. The modality for treatment of end-stage liver disease is liver transplantations is the only effective treatment for end-stage liver disease. But the demand and the availability of this service not in balance, because increased number of patients with end-stage liver disease die while they're waiting for liver transplantation, and there is a need to develop the strategy for alternative therapy that already showed by 2 previous speakers. And alternative treatment in end-stage liver disease is stem cell therapy. Stem cell therapy has brought promising benefits to patients with various disease, and maybe also potential alternative for patients with end-stage liver disease. The definition of stem cell is the parent cell that has an ability to divide it and develop into different cells in the human body. And these cells have a potential to replace destroyed cells and also tissue, and can develop these cells can be developed from the blood cells, also neuron and cardiac cells. These days, the the use of stem cell mostly come from bone marrow, and this is mesenchymal stem cell is the most popular stem cell that used in the treatment of various conditions. The stem cell also can be autologous. Autologous means that the stem cell come from the patient itself, and also can be from allogenic. And this may be from umbilical cord blood or other organs from different people. The source of the stem cells can be from bone marrow or peripheral blood, and from allogenic, the stem cell come from also from bone marrow and peripheral blood, and also from umbilical cord. This is the difference between autologous and allogenic stem cell. The important one is the aspect of cost. Autologous is expensive because there are several stages to process this stem cell to be used in human body, and but allogenic relatively cheaper, that did not require fasting from patient's own body. And also, but the social issue and also the ethical problem with the autologous is more secure in ethical problem. But the allogenic, such as umbilical cord cells, stem cells, is a little problematic. And in our condition in Indonesia, with the decree from the Ministry of Health, stem cell can be used as treatment modality, but not for commercial purpose. Type of stem cells can be totipotent or pluripotent, and can be multipotent. And this can use for several types of cells to be used in the clinical setting. For liver cirrhosis, the stem cell can strengthen the immune system from immunomodulations, and also can repair the liver conditions, which is in the end-stage liver disease. The fibrosis is intensive, so this stem cell can manage or attenuate the fibrosis in this kind of disease. So the stem cell implantation can be given by infusion to generate damaged liver, and it's possible to stimulate liver function and reduce scarring of the liver. Several factors should be bear in mind. First is the species of the stem cell. It can be autologous or allogenic, can be from the mesenchymal or from the umbilical cord. Injection route of the stem cell. This can use the hepatic artery, or from the portal vein or peripheral venous, or directly injected into the liver or spleen. The dosage of the stem cell, until now there's no large sample size of stem cell experiment to explore the optimal dose of stem cell. So different clinical trial, maybe also different clinical result. Other factors is therapeutic effect of the stem cell. The stem cell can improve liver biochemical index or liver function. However, some clinical trials have shown the opposite. And also, last but not least, the adverse effect and complications of the use of the stem cell must be also considered. The progression of stem cell therapy in the world for liver disease. This is the recent publication, systematic review and meta-analysis for the combination therapy with adult stem cell and traditional medicine for treating end-stage liver disease. From several studies, it can be shown that the total bilirubin is better in combination therapy of liver stem cell and transplantation versus traditional therapy. Also, the albumin levels also better in patients with combination therapy versus traditional therapy. And this usually happen after more than 2 weeks. Yeah, after more than 2 weeks for the treatment until the transplantation. ALT levels also better in patients with combination therapy. Also happen in more than 2 weeks, and also in the AST level. And as the whole, the liver function measured by the child Tooth score is also better in combination therapy versus traditional therapy. The child Tooth score is significantly lower at more than 4 weeks of treatment. So the conclusion of the study that we can benefit from adult stem cell combined with conventional medicine and better than those of the traditional treatment only. However, this efficacy gradually declined with the extension of the follow-up duration. But one study in phase 2 study of human allogenic liver-derived progenitor cell therapy for acute and chronic liver failure and also acute decompensation of liver disease. This study designed to use human allogenic liver-derived progenitor up to 28 days in patients with acute and chronic liver failure and also acute liver decompensation. And they showed that the patients may have an adverse event that occurring during the first 28 days of the study. But in their experience, the early patients that are severe adverse bleeding events have a high dose of stem cells therapy. After the dosage is reduced, there's no adverse events related to treatment. And the other adverse events were in the phase with expected patients with HALF and acute decompensation of the liver. And they also showed that the prognosis scores in this safety analysis set is lower in patients given the stem cell at the 3 months of the treatment. So how about the stem cell therapy in Indonesia? The use of stem cell in the world in several clinical conditions, also in liver cirrhosis. But until today, there is no official data from our Ministry of Health, the number of stem cell produced and alternative therapy in Indonesia. And RSKM only has data that treated using stem cell in RSCM. So the Minister of Healthcare decree is prohibited the stem cell for commercial use. Also, the care for the use of umbilical stem cell. Actually, the stem cell can be used in mesenchymal stem cell, also hematopoietic stem cell for treatment of end-stage liver disease. Who is allowed to give stem cell therapy? And this is RSCM until now. Maybe correct me if I'm wrong, that this is the one hospital that appointed by government to provide stem cell therapy for the patients. So this is all that I want to share with you. And thank you for your attention.
Thank you, Prof. Rino. So thank you for the presentation that gave us knowledge about the hope of the stem cell therapy for liver disease. And now we are entering the time for question and answer. And now there are several questions for each presentant. So the first for Dr. Yudan, there is a questions about the challenges in biofabrications. So what is the challenges in biofabrications to support the cell therapy for liver disease?
Thank you, Dr. Bella. So
Yes.
allow me to answer. So thank you for the attention. And I think there are so many challenges that until now is still great things. And everyone is working on the hepatics. But most of them is, I believe that there is a very less research group that are succeeded in working with multi-cell types. So I think that is the one challenges that I would like to address. That is so that is why then we are hoping that this bioprintings would contribute in the strategy to do the multi-cell types, or sometimes we refer them as multi cells. Yeah, I forgot the term. I believe that Dr. Nana could help me. And the second one is
heterotypic culture, heterotypic organoid culture.
Yeah, yeah. Yes, it is. It was. And then in terms of the engineering, it is really hard to make random structures but interconnected. I think that is the big challenge. Yes. Inside in terms of the engineering, because we know that the nature product is random, but we as a human, we could only think as a arrange and in patterns. So that is I think what we need to translate. We need to make good translations based on our capability to answer those challenges. I think that will be most things that we need to address. And I'm very happy to be invited with a group of Dr. Nana, that we are hoping that we could do something in the SINTA project. I think that will be all, Dr. Bella. Thank you for the questions.
Thank you, Dr. Yudan. I also can see that there is a nice collaboration here. So I think this is for Dr. Nana. So from the presentation, we all know that there are several methods to produce hepatocytes, such as direct differentiation from fibroblasts, iPSC, and others. And for all of them, which technology is the most ready to apply? And because I think it's way too far from clinical trial due to the complexity of the method. So, and also for Sinta, can we use the technology for other type of cells, let's say cardiomyocytes?
Thank you for the question. So first of all, regarding the choice, regarding the choice of techniques or technology available, what we are currently performing here with Dr. Cynthia is that we give clinicians options. It's better to have options than have only one product, and then when you test it in the clinical trials, it does not work. So I think it's important for us to give options. So the option of direct programming hepatocytes is very important and indicated for patients who wishes to have their own cells, hepatocytes coming from their own cells. So then they can have a skin biopsy, and then we can culture the fibroblasts in the lab, and then convert those fibroblasts into hepatocytes and directly transplanted back autologously to the patients. Okay, so that is one option. Okay, for the Shinta, why are we focusing on the Shinta? Because I think this can be very important, not only in terms of for the patients, but also for capacity building and collaboration with laboratories across Indonesia, increasing the capacity of stem cell labs in Indonesia by educating next stem cell scientists and stem cell laboratories, so they can also, if we develop from Jakarta, if we develop the liver microstructures in Jakarta, and in the periphery lab, they can thaw this microstructure and then place it in the compartments, in the Shinta compartments. And hepatolog, consultant hepatolog in the periphery of Indonesia, they can monitor this patient. They can monitor this patient, and they can also consult. So I think it's not only regarding the patient's benefits, but also the benefits for medicine in whole and biomedicine researchers in whole, biomedical engineering researchers in whole as well, because we will not be able to have those millibioreactors if it's not for the engineers. Okay, so I think that's the question for, the answer for the first question. For the second question, whether Sinta can be applied elsewhere for other organs, other complicated organs. Well, I don't know whether I'm supposed to say this or not, but we do have another project ongoing. It's under Professor Mulyadi. Professor Mulyadi is the lead investigator, and the principal investigator is also Dr. Winda Askiani from Harapan Kita, pediatric cardiologist. So they are developing this cardiac patch for congenital heart disease. Okay, so but this is still very early on. So as you notice, with the liver, we started in 2015, and at 2021, we are now with the Shinta. Okay, so with the cardiac patch, we are beginning slowly. So we are testing the differentiation protocol first, differentiation of iPSC into cardiomyocyte first, whether it can work or not. And then afterwards, we can develop it better. Of course, there are several steps that can be skipped from the Shinta step, but it's a working process. It's still early on the process, so I don't know where it will go. Okay.
Thank you, Dr. Nana. But by hearing from this meeting, yeah, we know that we have a hope. Yeah, we have a hope that make us very motivated to waiting. Yeah, the next research from Dr. Tadiana, Dr. Yudan, and also Prof. Rino result, yeah. And then for the next question, maybe this is the last because of our time, yeah, because there are several questions actually, but we have to limit, we have limitation in the time. So for Prof. Rino, the final result that all we hope from this journey is to cure or giving a bridging therapy for patient in waiting list for the liver donor to improve the life expectancy. So from the various methods and sources that already mentioned before, so there is two questions, Professor. So actually, what is the best actually choice of the cells, or maybe the combinations that has the best probability for the therapy? And then what is the second question is, what is the most feasible route of administrations to the patients in clinical trial? Sorry, Professor, you still mute?
Okay, thank you for the questions. I think until now we don't know yet what is the best source for liver stem cells. Several studies already use the mesenchymal stem cell, also the hematopoietic stem cells, and yeah, actually the umbilical cord stem cell already also used, but we don't have a comparison, head-to-head from different kind of source of the stem cell. And actually we still in the phase of learning whether stem cells is very useful way of treating patients with chronic liver disease or end-stage liver disease. So the answer, which is the best source, not until now, not determined yet. And for the other questions, actually the stem cell can be given intra-arterially or can be given intraperitoneally or intravenously. These stem cells, it said that these stem cells have some kind of home marker or something like that that brings this stem cell to the organ that needs these stem cells. But I think the most efficiently is from the arterial line directly into the hepatic artery. I think this is maybe the one that we should develop. But that is the most economically is from the intravenous line. I think maybe not really satisfied. The answer is not really satisfied, but until now we are still learning in the field of using the stem cell for end-stage liver disease.
Okay, thank you very much, Prof. Rino. So I think this is the end of our meeting, but we still have so many things yet that we want to discuss from our amazing speakers today. But because of the time, we have to close the sessions. But thank you very much. Yeah, we have now know that we have a hope. Yeah, in IMERI, in RSCM, in FMUI, now is developing the way for us to support the future therapy for liver disease. Thank you for all speakers. Thank you for the participants, and thank you for the committee. I give back the time to MC Dr. Sukma Dewi.
Welcome back to the 6 Eyes on IMERI second day, Hall B. Be prepared for our next session, concurrent session 10, maternal nutrition, missing pieces and way forward in daily practice. The session will be moderated by Dr. Nurul Ratna Mutumanikam, Magister of Nutrition, Health Nutrition Specialist. Dr. Nurul Ratna Mutumanikam finished her health nutrition specialist at Universitas Indonesia in 2014, and now she is active as the head of nutrition department, Faculty of Medicine, Universitas Indonesia, and also PhD candidate in Faculty of Medicine, Universitas Indonesia. For Dr. Nurul Ratna Mutumanika, Magister of Nutrition, Health Nutrition Specialist, the floor is yours.
Okay, thank you for the host of meeting. Good afternoon, ladies, gentlemen, and colleagues. Thank you for joining the Eyes on IMERI 2021. My name is Nurul Ratna as a moderator for this session. I will guide this session for the next 1 hour. And to all participants, thank you for taking your time to attend this webinar. This session is named Maternal Nutrition, Missing Pieces and Way Forward in Daily Practice. And we are pleased to inform you that among us here, we had 3 expert speakers. The first speaker is Dr. Rima Irwinda, and the second is Dr. Rina Agustina, Master of Science PhD, and the last is Mrs. Yuni Dwi Setiawati, Sarjana Gizi, MHID. First, I would like to invite Dr. Rima Irwinda. She is an obstetrics and gynecology specialist, fetal-maternal consultant. She is from Medical Faculty of Medicine, Universitas Indonesia, and also graduated from Specialty Trainings of Obstetric and Gynecology, Faculty of Medicine in Universitas Indonesia, and also fetal-maternal medicine training in Universitas Indonesia, and also doctorate programs in Universitas Indonesia. And now she is also a fellowship from Australia Awards Fellowship, Building Nutritional Capacity to Strengthen Sexual Reproductive Health Services in ZAA in C region 2018, University of Sydney. Now, Dr. Rima Irwinda will present a brief explanation concerning missing nutrient in maternal nutrition and its consequences, vitamin D, and polyunsaturated fatty acid. To Dr. Rima, the time is yours.
Trimester kedua dan trimester ketiga membutuhkan protein, lemak, karbohidrat, besi, kalsium, dan multivitamin dan mineral, dan pada saat menyusui juga membutuhkan protein, lemak, kalsium, besi, dan vitamin D. Idealnya mikro dan makronutrien ini didapatkan dari makanan. Namun kadang-kadang dengan berbagai alasan, kita tidak bisa mencukupi kebutuhan ini dari makanan saja, sehingga ada negara yang melakukan fortifikasi makanan untuk mencukupi kebutuhan warga negaranya atau populasinya. Dan juga terkadang pada beberapa kasus kita juga membutuhkan suplementasi, bahkan dosis terapi untuk mencukupi kebutuhannya pada saat prakonsepsi, selama kehamilan, dan juga pada saat menyusui. Kalau kita lihat peran nutrisi ini bukan hanya berperan pada kehamilan saja, nanti akan ada di slide berikutnya, bahwa nutrisi juga berperan pada proses fertilisasi. Dan juga pada masa konsepsi, implantasi, perkembangan plasenta, kehamilan yang semakin berlanjut, dan menyusui. Kebanyakan dari ibu-ibu hamil di Indonesia itu melakukan pemeriksaan pada saat proses implantasi dan perkembangan plasenta, di mana terjadi pada saat usia kehamilan mungkin sekitar 4 minggu dari hari pertama haid terakhir, atau 2 minggu setelah fertilisasi, atau hingga sampai 8 atau 9 minggu. Jarang sekali yang melakukan pemeriksaan prakonsepsi untuk menanyakan persiapan apa saja yang dibutuhkan pada saat sebelum hamil. Apabila terjadi defisiensi mikronutrien pada proses-proses ini, maka kita bisa menemukan berbagai komplikasi sebagai contoh infertilitas apabila ada kegagalan pada fertilisasi, atau beresiko terjadinya abortus, atau beresiko terjadinya recurrent pregnancy loss atau keguguran berulang, preeklamsia, kelahiran preterm, diabetes mellitus gestasional, pertumbuhan janin terhambat, dan juga bisa berpengaruh terhadap perkembangan janin. Ini adalah berbagai mikronutrien yang dibutuhkan sejak perikonsepsi hingga perkembangan dari organ janin, di mana pada saat perikonsepsi membutuhkan vitamin B6, B12, dan folat. Pada implantasi, salah satunya membutuhkan vitamin D, selain juga membutuhkan zinc, selenium, asam folat, dan vitamin B12, di mana apabila terjadi kegagalan pada implantasi, beresiko terjadinya abortus hingga recurrent pregnancy loss atau keguguran berulang. Pada saat pembentukan vaskular, vitamin D juga berperan selain asam folat, besi, zinc, dan juga kuprum dan selenium, di mana apabila vaskularisasi ini menjadi tidak adekuat, resiko terjadinya invasi trofoblast yang tidak sempurna dan juga remodeling dari arteri spiralis yang nantinya beresiko terjadinya preeklamsi. Transfer nutrisi dari ibu melalui plasenta ke janin juga akan mempengaruhi pertumbuhan janin yang nantinya beresiko terjadi pertumbuhan janin terhambat, dan juga akan mempengaruhi pembentukan organ baik morfologinya maupun fungsinya. Banyak sekali yang berperan terhadap perkembangan organ janin, contohnya adalah vitamin A, folat, kuprum, besi, zinc, dan juga vitamin D berperan untuk perkembangan neurologis dari janin sendiri. Kalau kita lihat di uterus dan juga salah satunya di myometrium dan plasenta, kita bisa menemukan vitamin D reseptor, enzim-enzim yang mengaktifasi vitamin D dalam bentuk inaktif menjadi aktif, sebagai contoh CYP27B1. Di myometrium ditemukan adanya vitamin D reseptor, begitu pula di desi2 basalis. Selain ditemukan CYP27B1 yang mengaktifasi 25-OHD, yaitu bentuk inaktif vitamin D, menjadi bentuk aktifnya, yaitu 125-OH2D3. Di sinsitiotrofoblast dan juga di sitotrofoblast ditemukan vitamin D reseptor dan CYP27B1 terutama di sinsitiotrofoblast. Sedangkan sitotrofoblast selain vitamin D reseptor juga ditemukan retinoid reseptor. Begitu pula di extraphilus trofoblast juga ditemukan vitamin D reseptor dan enzim untuk merubah vitamin D dalam bentuk aktif menjadi dalam bentuk inaktif. Salah satu peran dari vitamin D adalah meregulasi respon imun yang sangat dibutuhkan pada saat kehamilan, di mana pada saat implantasi, supresi dari imun yang aktif itu diperlukan untuk mencegah terjadinya rejection dari embrio yang berkembang, di mana dalam hal ini yang berperan sangat penting salah satunya adalah T regulator dan juga T helper 1. Kalau kita lihat vitamin D itu berperan menurunkan T helper 1 dan juga menurunkan T helper 17 dan meningkatkan T regulator dan T helper 2. Selain itu, vitamin D juga menurunkan sitokin-sitokin proinflamasi seperti contohnya interleukin 6 dan TNF-alpha dan interleukin 1 beta, dan juga meningkatkan produksi dari antimikrobial peptide, misalnya adalah katelesidin. Dan peningkatan antimikrobial peptide dan penurunan sitokin proinflamasi ini dibutuhkan selama kehamilan. Tujuannya adalah untuk mencegah terjadinya persalinan preterm atau usia kehamilan kurang dari 37 minggu. Apabila terjadi defisiensi vitamin D selama kehamilan, maka risiko terjadi keguguran dan kelahiran preterm. Ini adalah peran vitamin D berbagai organ. Sebagai contoh di pankreas, vitamin D menurunkan resistensi insulin, sehingga apabila terjadi defisiensi, risiko terjadi diabetes mellitus gestasional. Tadi sudah dikatakan di slide sebelumnya bahwa vitamin D juga berperan pada respon imun sehingga mencegah terjadi kelahiran preterm, recurrent pregnancy loss, dan juga pada bayinya menurunkan kejadian asma dan penyakit alergi yang lain. Sedangkan pada ginjal, vitamin D ini meregulasi tekanan darah sehingga mencegah terjadinya preeklamsi, sedangkan di tulang dan otot meregulasi dari densitas tulang dan kekuatan otot sehingga mencegah terjadinya janin kecil masa kehamilan, sedangkan di otak mencegah terjadinya depresi pada ibunya pada saat postpartum dan juga autism pada anaknya. Ini adalah telah sistematik yang dilakukan oleh Concurrent bahwa suplementasi vitamin D selama kehamilan bisa menurunkan kejadian preeklamsi sebesar 52%, diabetes mellitus gestasional 49%, perdarahan postpartum 32%, dan berat badan lahir rendah 55%. Dengan kalau kita lihat grade di sini, suplementasi vitamin D cukup baik untuk preeklamsi, diabetes mellitus gestasional, dan berat badan lahir rendah. Kalau kita lihat ekspresi vitamin D reseptor itu ditemukan pada organ reproduksi baik laki-laki maupun perempuan. Misalnya di laki-laki ditemukan VDR di sel Sertoli, sel Leydig, germ cell, spermatozoa, sedangkan di perempuan ditemukan di uterus, ovarium, dan juga pada kehamilan yaitu plasenta. Apabila terjadi defisiensi vitamin D pada laki-laki akan menurunkan kadar androgen sehingga menyebabkan spermatogenesis yang abnormal dan motilitas sperma juga yang abnormal. Sedangkan pada perempuan apabila terjadi defisiensi akan terjadi penurunan dari kadar AMH dan juga berhubungan dengan PCOS, kista endometriosis, miom, dan juga apabila vitamin D-nya cukup meningkatkan kemungkinan lahir hidup pada ibu-ibu yang jalani program bayi tabung atau IVF. Dan dikatakan pada penelitian yang ada, apabila konsentrasi vitamin D itu ditingkatkan sebelum konsepsi, ini lebih meningkatkan kemungkinan terjadinya pregnancy atau kehamilan klinis dan kelahiran hidup dan berhubungan dengan penurunan pregnancy loss atau keguguran. Dan juga pada wanita-wanita yang menjalani IVF dengan kadar vitamin D yang cukup, kemungkinan untuk positif hamilnya lebih besar dan kelahiran hidupnya pun juga lebih besar dibanding wanita-wanita yang defisiensi vitamin D. Vitamin D defisiensi juga berhubungan dengan recurrent pregnancy loss atau keguguran berulang, di mana pada pasien-pasien dengan defisiensi vitamin D terjadi peningkatan prevalensi dari anti-phospholipid antibody, ANA, dan anti-single-stranded DNA, sehingga hal ini beresiko untuk terjadinya recurrent miscarriage. Pada penelitian juga didapatkan bahwa pada pasien-pasien dengan recurrent miscarriage terdapat kadar CYP27B1, yaitu suatu enzim yang mengaktifasi 25-OHD dalam bentuk inaktif menjadi aktif, yaitu 125-OH2D3 yang lebih rendah di Villi chorioalis, dan juga ekspresi vitamin D reseptornya pun juga lebih rendah pada pasien-pasien yang RPL di Villi chorioalis, DESI2, dan serum dibandingkan wanita yang hamil normal. Selain itu, apabila kita bisa mencapai kadar vitamin D yang cukup, yaitu 40 nanogram per mililiter, dikatakan bisa mengurangi kemungkinan kejadian hipertensi dalam kehamilan, penurunannya sebesar 56%, dan kemungkinan kelahiran preterm turun hingga 60%. Selain itu, vitamin D juga berperan pada perkembangan saraf janin dan juga bayi. Ada banyak sekali penelitian yang mencoba melihat hubungan prenatal vitamin D dan neurodevelopment. Sebagai contoh, penelitian yang dilakukan oleh Morales, di mana bayi-bayi dengan ibu konsentrasi 25-OHD pada saat trimester awalnya di atas 30 nanogram, memiliki kognitif yang lebih baik dibandingkan bayi-bayi yang lahir dari ibu yang kadar vitamin D dalam serumnya kurang dari 20 nanogram per mililiter. Begitu pula skor psikomotornya pada saat usia 14 bulan dan 30 bulan ini juga lebih baik pada bayi-bayi yang lahir dari ibu yang vitamin D-nya lebih tinggi. Hubungan vitamin D terhadap ADHD dan ASD juga banyak yang sudah melakukan penelitian di mana karakteristik atau gejala ADHD pada anak-anak usia preschool atau 4-5 tahun itu akan lebih turun, akan lebih sedikit atau lebih kecil, kurang lebih 11% dengan peningkatan kadar vitamin D ibunya pada saat usia kehamilan 13 minggu. Jadi artinya kalau misalnya seorang ibu pada saat usia kehamilan 13 minggu kadar vitamin D-nya lebih tinggi, maka kemungkinan ADHD atau gejala yang berhubungan dengan ADHD pada anaknya akan lebih kecil kemungkinannya. Penelitian yang berhubungan dengan autism juga sudah ada yang melakukan bahwa terutama defisiensi vitamin D pada saat trimester kedua dan pada saat neonatal itu juga berhubungan dengan autism spectrum disorder. Ini suatu gambaran, meskipun dikatakan kadar vitamin D normal itu adalah 30 nanogram per mililiter, sebenarnya yang optimal untuk mencegah komplikasi selama kehamilan sebagai contoh kelahiran preterm, preeklamsi, diabetes mellitus gestasional, atau janin kecil masa kehamilan itu yang dianjurkan adalah kadar vitamin D 40 nanomililiter. Penelitian yang kami kerjakan di Jakarta pada tahun 2017 publikasinya kurang lebih 230 ibu hamil trimester 1, kami mendapatkan 99% ibu hamil tersebut memiliki kadar vitamin D kurang dari 30 nanogram per mililiter, artinya defisiensi dan juga insufisiensi. Penelitian yang dilakukan oleh Hollis dan kawan-kawan, kalau kita ingin mencapai kadar vitamin D 40 nanogram per mililiter pada saat selama kehamilan, maka yang paling baik adalah dengan menggunakan vitamin D 4000 international unit dibandingkan vitamin D 2000 international unit atau 400 international unit yang bisa dilihat di gambar di sebelah kanan, di mana pada pasien-pasien yang mendapatkan vitamin D 4000 international unit ini bisa mencapai kadar vitamin D 40 nanomol per liter, artinya sekitar 20 nanomol per liter itu pada saat usia kehamilan 16 minggu. Endocrine Society juga membuat suatu rekomendasi berapa dosis vitamin D yang dibutuhkan selama kehamilan. Kalau kita mengikuti dari rekomendasi Institute of Medicine, yang dibutuhkan selama kehamilan adalah 600 international unit. Namun Endocrine Society merekomendasikan apabila seorang pasien dengan resiko defisiensi vitamin D, maka bisa diberikan 1.500 sampai 2.000 international unit per hari, dengan upper limitnya 10.000 international unit per hari, atau bisa juga diberikan 50.000 international unit per minggu selama 8 minggu. Lalu di maintenance dengan pemberian 1.500 sampai 2.000 international unit. Kalau kita lihat kadar vitamin D serum ibu itu akan berhubungan dengan kadar vitamin D di dalam tali pusat. Dan dikatakan konsentrasi di dalam serum ibu lebih dari 50 nanomol, maka 90% kita akan menemukan kadar vitamin D di dalam serumnya itu lebih besar dari 30 nanomol. Jadi ini ada korelasi positif antara kadar vitamin D ibu dan juga kadar vitamin D di dalam tali pusat. Topik berikutnya adalah mengenai PUFA atau polyunsaturated fatty acid. Kalau terjadi defisiensi vitamin D selama kehamilan, baik asupannya yang kurang atau metabolisme fatty acidnya yang disfungsi atau mengalami perubahan, maka resiko terjadinya infeksi trofoblast yang tidak sempurna dan juga remodeling arteri spiralis yang incomplete, sehingga hal ini menyebabkan peningkatan dari radikal bebas dan resiko terjadinya stres oksidatif yang menyebabkan preeklamsi dan juga kelahiran preterm. Dan juga beresiko untuk terjadinya pertumbuhan janin terhambat. Di mana ketiga hal ini pada saat bayi tersebut dilahirkan, beresiko terjadinya penyakit tidak menular, contohnya adalah hipertensi, penyakit kardiovaskular, stroke, dan juga dislipidemia. Ini adalah fungsi dari DHA dan ARA, di mana DHA bisa kita lihat memiliki efek sebagai antiinflamasi dan juga bersifat sebagai antiproliferasi dan antihipertensi, dan juga berpengaruh terhadap modulasi respon imun dan juga pembentukan neurodevelopment. Sama seperti DHA, ARA juga berperan sebagai neuroinflamasi, menurunkan neuroinflamasi dan bersifat sebagai neuroproteksi, di mana apabila terjadi defisiensi selama kehamilan baik DHA, bisa beresiko terjadinya kelahiran preterm, preeklamsi, dan diabetes mellitus gestasional akibat peningkatan dari inflamasi dan juga efek antihipertensi yang hilang. Ini adalah berbagai mikronutrien yang dibutuhkan untuk perkembangan saraf, salah satunya adalah vitamin D dan juga PUFA. Kalau kita lihat di gambar di sebelah atas yang kursor saya gerakan, ini kita bisa lihat bahwa pembentukan neuron itu sudah mulai terjadi pada saat usia kehamilan 2 minggu setelah fertilisasi. Jadi kalau kita lihat kebanyakan ibu hamil belum melakukan pemeriksaan kehamilannya. Apabila terjadi defisiensi mikronutrien ini, sebagai contoh vitamin D atau PUFA atau besi, maka pembentukan neuron, sinaps, mielin ini menjadi tidak efektif, sehingga nantinya di kemudian hari akan beresiko terjadinya gangguan perkembangan kognitif, gangguan perilaku, autism, dan juga attention deficit hyperactive disorder. Jadi, bukan hanya PUFA dan vitamin D, sebenarnya banyak juga nutrisi lain yang dibutuhkan untuk perkembangan saraf. Ini adalah penelitian yang menunjukkan pada pasien-pasien diabetes mellitus gestasional bahwa pemberian suplementasi vitamin D ditambahkan dengan omega 3 bisa menurunkan kadar gula darah atau fasting plasma glucose dan juga bisa menurunkan HOMA-IR yang artinya memperbaiki sensitivitas insulin, menurunkan trigliserid, menurunkan kolesterol LDL dan juga LDL, dan meningkatkan HDL. Penelitian yang kami kerjakan pada ibu hamil trimester 1, LC-PUFA, dan kita lihat di sini yang merah ini artinya ada kekurangan, bahwa kebanyakan kekurangan omega-6, linoleic acid, dan asam arachidonat, dan begitu pula omega-3 kan kekurangan ALA dan juga DHA. Dan ini yang menjadi PR untuk kita untuk melakukan edukasi makanan-makanan apa saja yang bermanfaat untuk meningkatkan atau yang sebagai sumber PUFA, atau apabila dibutuhkan maka kita bisa menambahkan suplementasi. Ini penelitian kami yang lain yang menunjukkan bahwa pada pasien-pasien preeklamsi memiliki omega-3 indeks yang sangat rendah, yaitu di bawah 2,5, dan ini meningkatkan resiko terjadinya preeklamsi hingga 6 kali. Begitu pula pada kelahiran preterm, kami dapatkan bahwa kadar DHA-nya lebih rendah dibandingkan kontrol. Begitu pula kadar EPA lebih rendah dibandingkan kontrol. Nah, ini bisa kita atasi dengan salah satunya edukasi pola makan dan juga memberikan suplementasi. Kalau kita lihat ketersediaan nutrien berdasarkan negara pada tahun 2013, kita bisa melihat bahwa ketersediaan nutrien di Indonesia, baik zinc, vitamin A, besi, dan PUFA itu kebanyakan kurang atau sedikit. Dan hal ini mungkin memang tidak diherankan bahwa intake di kita pun dianggap kurang, terutama untuk besi dan juga PUFA dan juga zinc. Yang direkomendasikan pemberian DHA selama kehamilan adalah 200 mg per hari, sedangkan total PUFA-nya adalah 15,4 gram per hari. Dan penelitian yang kami kerjakan dengan menggunakan food frequency questionnaire, kami dapatkan bahwa intake-nya hanya 4 gram per hari, jadi jauh dari rekomendasi. Ini adalah sumber-sumber makanan yang mengandung DHA, sebagai contoh ikan tuna, juga ikan kembung, ikan tongkol, telur, dan ini bisa kita rekomendasikan untuk ibu-ibu hamil untuk meningkatkan area selama kehamilan. Ini slide terakhir dari saya, begitu banyak penelitian yang mencoba melihat suplementasi DHA dan pertumbuhan dari neonatal dan kognitifnya, dan bisa dilihat bahwa pemberian DHA 600 mg per hari bisa meningkatkan ukuran dari janin dan memperlama usia kehamilan, dan kombinasi DHA dan EPA meningkatkan perkembangan kognitif dan juga memorinya juga lebih baik dibandingkan ibu-ibu yang tidak mendapatkan suplementasi selama kehamilan. Terima kasih atas perhatiannya. Apabila ada kekurangan saya mohon maaf. Assalamualaikum warahmatullahi wabarakatuh.
Well, thank you, Dr. Rima, for the nice presentation. And now I would like to invite Dr. Rina Agustina as a second speaker today. Dr. Rina Agustina, Master of Science PhD, has education experience in medical doctor from Gajah Mada University, and she also graduated from Master of Science in Nutrition in Universitas Indonesia and PhD in Human Nutrition in Wageningen University. Now, the current position as a head of Human Nutrition Research Center in IMERI FKUI and as a lecturer at Faculty of Medicine Universitas Indonesia. Dr. Rina will deliver a presentation about missing nutrition in our nation, dietary quality and micronutrient intake in pregnant women of Indonesia. So Dr. Rina, the time is yours. 20 minutes for you, Dr. Rina.
Thank you, Dr. Nurul. Assalamualaikum warahmatullahi wabarakatuh. Again, thank you for Madam Chair and good morning, everyone. As mandated from the ICE on IMERI committee, I would like to present the missing nutrition in our nation. Would like to focus on dietary quality, macro and micronutrient intakes in pregnant and lactating women of Indonesia based on our current studies. So I'm Rina Agustina from Department of Nutrition and Human Nutrition Research Center. As mentioned, we would like to highlight on the maternal intake comparison Indonesia and Malaysia. We also will highlight on the niacin intake specifically on how this actually affect on the congenital malformation, and as well as the published study on maternal dietary quality among pregnant women. WHO already gave a very strong statement that maintaining good nutrition and healthy diet during pregnancy are critical for the health of the mothers as well as the unborn child. And if we see from the nutrition through the life cycle, this good nutrition is essential during pregnancy to prevent any adverse pregnancy outcome, such as low birth weight, which actually can carry over to become child stunting and adolescent stunting, which actually influence also the pregnancy low weight gain. And the nutritional needs of women, therefore, should increase during pregnancy and breastfeeding to maintain the maternal hemostasis and also ensure the normal development of the fetal growth. So here we see that the nutritional guidelines showing that the nutrition intake requirements recommended for pregnancy increase significantly through trimester from the first to second to third trimester, as also mentioned by Dr. Rima previously. Thus, it is pivotal to ensure the pregnant women had appropriate nutrient intake. So here's some highlight of the increment of some of the nutrient requirement: energy, protein, vitamin A, folate, calcium, zinc, iron for second and third trimester. But this is something that we also will highlight on our study. And it also with lactating women. Mother's diet, we know that might influence breast milk production and composition. So it is essential for mothers to consider the nutrient intake as well as the quality of food consumed. As we see here, increment of energy, protein, fat, vitamin A, calcium, zinc. We also will highlight this. We will limit on these particular nutrients, although some other nutrients like omega-3 and also other potential the amino acids are very interesting, but we will focus on these particular nutrients. Although it's the recommendation is quite important to increase the requirement, but we see that the nutritional problem among pregnant women in Indonesia are very high burden, as seen from the anemia is commonly occurred among Indonesian pregnant women and kept increasing through the years. From 2013 to 2018, more than 10% increment. Although we see the chronic energy deficient decreasing on the prevalence, but still being a public health problem. And we also do not know whether this decreasing of the CED following also the improvement of the iron intake among the pregnant women. So from the studies, we know that this is based on our study, poor dietary quality among healthy and pregnant women in Indonesia. And this pattern also similar to the pattern of the indigenous and also pregnant women in Malaysia. However, there's no such a systematic review following this particular intake, which is very important for the future policy. And we actually did a systematic review and meta-analysis to actually look at the nutrient intake adequacy among pregnant and lactating women in Indonesia and Malaysia, the countries which experience rapid nutrition transition in Southeast Asia region. This is colleagues from the Human Nutrition Center and Department of Nutrition, which actually did this study. So we actually identify about more than 2,000 articles, and we screened about 1,600, about 53 total study included after removal of duplicates, and also full text assess, and we include this study. From this study, we found the overall maternal nutrient intake comparing the pregnant and lactating pregnant women in Indonesia and Malaysia. If you see here, all nutrients seems to be below the recommended dietary allowance or the recommended nutrient intake, in both countries. But in contrast, if we see the protein intake are very low in Indonesian pregnant women as compared to Malaysia, and also on some of the carbohydrate and fat, which actually is showing how actually this difference might actually also come up with different potential health outcomes. And we look at more carefully also on lactating women, And we found also similar pattern where the protein intake seems to be much different, although the other nutrients are almost similar. But if you look at niacin and folate, much of that particular lower than the other nutrients, but there's no such an information in Malaysian lactating women. So let's look at one by one. Then we actually summarize on the meta-analysis of these studies, and we found that the protein intake during pregnancy in Indonesia and Malaysia overall is actually failed to meet the recommendation. But if you look at more to each country, all 4 studies from Malaysia indicated higher protein consumption than the national recommendation, with average excess of protein 5 grams per day, or about 6% of the RNI. And this actually in contrast with Indonesian protein intake of pregnant women, which actually deficit about 18 grams per day, which is actually quite a problem in our population. So how about then if you look at lactating women, the trend is also similar, also failed to meet the recommendation. And 2 studies in Malaysia indicated a higher intake of nutrient from national recommendation with excess about 16 grams, while Indonesia is deficit about 15 grams. So Indonesia, Malaysia lactating women tended to have protein intake also in overall lower, but then there's a difference between countries. So then we compare with the other studies from Asian countries. Indeed, on the protein intake during pregnancy, most studies of these particular nutrients as well as the energy intakes in Asia were relatively below from recommendation of that time. So then we also look at how about if you look at Malaysia, Indonesia, with also some other review done by Suhan et al. 2010, and we compare that this Malaysian intake, all studies had intake about 90% of RNI for protein, which almost similar with Vietnam and China. Whereas Indonesia, only 1 study found that intake exceed 100% RDA, while the other is lower than that, but range about 45 to 100, which is almost similar also with Thailand. So this is very interesting findings, which actually can give us some sort of information for policy. And how about the micronutrient intake? When we look at the vitamin intake during pregnancy in Indonesia and Malaysia, tended to have vitamin A intake higher as recommended. So vitamin A intake seems to be the most studies of the micronutrient. And this is actually quite different if you look at the studies on the vitamin D. So as mentioned by a previous speaker, vitamin D intake is very problematic, and this actually lower 0.46 standard deviation than the estimated average requirement, which is quite low. And also if we look at later on the other study from European countries, almost similar trend. How about the vitamin C, which actually quite interesting as well. This is actually failed to meet the ER, the estimated average requirement. It's insufficient, especially on the Indonesian studies, which approximately 39 or around only about 50% of the ER. And while the 3 studies in Malaysia reported that vitamin C intakes are greater than the ER. So then we look at the other studies on the Asian countries. Vitamin C intake usually are among the about 1.5 to 3.4 times greater than ER, which is actually similar to Malaysian study, but not much on Indonesian study. And the vitamin intake in all region between 1.7 to 35 times greater than ER, which is a bit similar to our findings in Indonesia and Malaysia. And for vitamin D intakes, if you look at here on European population, they also below from recommendation, which is also occur in Malaysia and Indonesia. So then we look at also on the minerals, especially on iron intake. So there's some findings showing that we are not very surprised about this one. The iron intake during pregnancy in Indonesia failed to meet the ER. And this efficiency, we know that very much contributed to iron deficiency anemia. And some studies showing that the habits of Indonesian pregnant women consume plant-based protein like tofu and tempeh were actually considered to be low in iron content, but which is not very much actually many studies showing the relationship with any adverse relation, although we see some studies also looking at that very carefully, but we are not much seeing that in this particular assessment of the review. But the condition are different from the lactation. In the lactation, the iron intake seems to be meeting the ER level, and from the 6 studies or about 596 lactating women indicated a tendency higher intake. The average excess both countries about 2.4 milligram. So this seems to be like they are having more appetite during lactation, and we would like to have better production of breast milk, which also highlight from these different studies. And how about the other nutrients like the other Maternal for calcium? The calcium intakes fail to meet ER, and this is actually conjunction also with the intake of vitamin D and also magnesium. And we also look at different findings, which is quite surprising for zinc intake, which shows a meeting ER level in contrast with the iron intakes or the calcium intake. Well, when we compare together with the mineral intakes from other studies showing that the calcium intake in Western countries tended to achieve more than 100% ER, which is actually quite different from our studies or our population, while the iron intake always below the nutrient recommendation, even in European countries, except the UK. While the zinc were greater from recommendation, which is also similar to our findings in Indonesian and Malaysian population. So that actually makes a lot of sense how actually the nutrient problems intake among the pregnant women and lactating women. So then we go more on the specific nutrient and how this actually relates to any adverse outcome. So we look at the influence of the prenatal niacin on congenital malformation, fetal growth, and survival. This is also systematic review and meta-analysis led by Dr. Anuradha Sankar from Oxford University with our colleagues from the Human Nutrition and Department of Nutrition. We compare the pregnancy outcomes related to prenatal niacin intake, intervention, or exposure to human, animal, and in vitro study. So we actually screen about more than 10,000 articles. It's a very big word, which actually later available full text about 23 for human studies, but none are actually randomized trial. Most are actually, all are actually observational study, and also 39 animal study, as well as 12 in vitro study, and also we did the manual search. So what we found here is actually quite interesting, because niacin was actually being a missing information before being ignored. And we found actually on this observational study, a protective effect of maternal niacin intake on birth defect, spina bifida, congenital heart defect, demonstrated in both human and animal study. And this niacin intake might reduce the congenital malformation by 24%. So this has not been there in randomized trial, but this actually gives quite important findings. And following that, we also look at how actually the niacin intakes might actually influence the fetal growth. So the maternal niacin intake improved fetal growth and tended to be protective for fetal death in animal models. So this study actually giving a significant yet small correlation between niacin intake and the birth weight. Yeah, so last, then we also did the dietary quality studies among pregnant women, especially on relation to blood pressure and weight gain. What findings actually very important, because what we found actually the dietary quality among pregnant women in urban society in Jakarta is actually only less than 50 out of 100 score, which is actually very, very low. And higher dietary quality was associated with lower diastolic blood pressure among pregnant women in urban low middle income country community, but not with systolic blood pressure and blood glucose. So it's also the same when we look at Indonesian pregnant women, and then following up the 3 years later, overall dietary quality was inadequate. Higher dietary quality score was associated with increased weight gain during pregnancy, about 3.3 kilogram, but not associated with other nutritional status issues during pregnancy and 3-year postpartum. And this is actually the other study that on maternal energy fat and omega-3 fatty acid, and showing that very low in EPA, DHA among pregnant women. So in conclusion, the energy and micronutrient intake among pregnant women and also lactating women were consistently below the recommendation. Vitamin D, E, water-soluble vitamins, calcium, and iron failed to meet the recommendation. Nutrient intake of Indonesian pregnant and lactating were still far lower than women in developed countries, which is not very surprising. Dietary quality in healthy and pregnant women were poor in urban area and associated with blood pressure and weight gain. And for the study on niacin, nutrient inadequacy during pregnancy and lactation has been widely associated with the growth and development of the offspring. Sufficient maternal niacin intake may prevent birth defect. Consume multiple micronutrients is essential to have a better effect on fetal growth development. While all these studies are being statistically reviewed, still study and development are lacking. So we would like to recommend further research required, particularly on micronutrient intake, as data is lacking, especially on randomized trial on niacin, and promote balanced diet as early as possible also helps improve maternal nutrition even before conception. The utilization of technology should be enhanced to promote nutrition and healthy diet. Therefore, mainstreaming the promotion of eating balanced diet as stated on nutrition guidelines is required to fulfill nutrition adequacy. We would like to acknowledge the Fund Challenges Canada, the Faculty of Medicine, Directorate General of Higher Education, Ministry of Education and Culture, Republic of Indonesia, and Nutrient Review and Niacin Studies from Blackmore Institute, Australia. Let's have fulfilling the national nutritional guideline. The power is in isi piringku on our plate. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Dr. Rina, for interesting presentations about dietary pattern in Indonesia and Malaysia. Now we have a last speaker. I would like to invite Mrs. Yuni Dwi Setiawati to deliver presentation. She is graduated from Bachelor of Nutrition and Health in Gajah Mada University, and also Nutrition and Dietetics in the same university in Gajah Mada University, and she is also a Master of Health and International Development, Flinders University. Her current position right now as a Senior Research Officer in Summit Institute for Development, or SID, and also Public Health Consultant in Zakat. Now, Mrs. Yuni Dwi Setiawati will deliver a presentation titled Genomic-Based Optimized Prenatal Nutrition.
Okay. Thank you.
The time is yours. Yes, please.
Yeah, thank you for attending the session today. And we got two great sessions by Dr. Rima and Dr. Rina previously. And shortly, I will talk more about the other missing piece on daily practice. I'm Yuni from Summit Institute for Development, and I think I asked the community to help me to present the presentation. Is that presentation ready to present it? Thank you. Okay, next I will deliver the topic called genomic-based optimized prenatal nutrition. And we believe that optimal pregnancy outcomes can be improved
and advanced through public health genomic and health precision approaches. And here, I will focus more on the concepts of how this approach can be translated into daily practice. So I will divide the presentation into several subtopics. I will first briefly introduce the Summit Institute for Development. Might be some of you are familiar, but some are not. And I will follow this discussion about the topics on public health genomic approach and precision health, with some missing pieces on how genetics factors can influence health and how, in macro level, the service for antenatal care can be improved through team-based care and technology use. Then we'll close the session with opportunities to put together these missing pieces to practice in primary care setting. Next. So here, Summit Institute for Development, or SID, is an NGO located in Mataram, Lombok, that has officially been established since 2007 after the largest trial in the world to assess the impact of multiple micronutrient supplementation on neonatal mortality and other pregnancy outcomes. So this study has been shaping global recommendation to provide multiple macronutrient supplements over iron folic acid, or IFA. So since then, we keep bringing our organization to work closely with the community and government partners to improve public health and human resource development. These are achieved through improvement of maternal, neonatal, and child health, improvement of human resources, and the use of technology at community level. Next. So many programs and research have been done by a Summit Institute for Development together with partners from international, local, and district partners. And our activities aim to create impact and benefit on our communities through research implementation. In every program, our main beneficiaries are pregnant women, babies, children, and also their families. Next. So as we know, the health of individual, including a pregnant woman, is influenced by multiple factors. Various models have been developed to describe the social or ecological determinants of health, the ways in which elements of the social, economic, and physical environments interact with individual biological factors and behaviors and shape health status. So some representative examples are provided in the slide. I summarized these factors into two, so the macro level and micro level factors. So the example of macro factors such as environment, social, politics, healthcare, and so forth, while the micro factors include biological, genetic, and behavioral factors. Next. So the precision public health is still in its infancy, but can be advanced more with genomic approach. So precision public health can be viewed as an emerging multidisciplinary field that uses genomics, big data, and machine learning intelligence to predict health risk and outcomes and to improve health at the population level. So the aim of precision public health is to provide the right intervention to the right population at the right time with the goal of improving health for all. So various core disciplines in public health are involved to fit the human genome into daily practice and application. Maybe you are familiar with the non-invasive prenatal testing, but this is only focuses on genetic abnormalities. So we need more to enhance this test to show bad things into something that's good, so everyone can be informed and know more than only abnormalities. For example, they will know more about their heterogeneity, so it can be tailored the treatment given to these specific groups. So on the pathogen side, actually the application of genomic based on whole genome sequencing is an example. So WGS, or whole genome sequencing, is fast becoming the standard assay for characterizing infectious disease and is potentially an incredible rich source of information to guide public health interventions. Next. I will move forward to discuss the first missing piece on daily practice related to genetic factors and its broad implication to optimize prenatal care. Next, I will take genetic polymorphism or gene variations in folic acid metabolism as a use case of anemic during pregnancy. As we know that during pregnancy, there is a normal change in blood volume expansion resulting from an increase in both plasma and erythrocytes. This can lead to low concentration of hemoglobin. As we know, women are recommended to take extra supplements as discussed earlier with Dr. Rima and also Dr. Rina, apart from daily dietary intakes containing several macronutrients needed for erythropoiesis, or the process by which red blood cells produce. They are folate, cobalamin or B12, and iron. We know that folic acid is critical to prevent neurotube defect and red blood cell formation. It is also known genetic polymorphism on the gene specific for folic acid can influence the level of metabolism of the element. So we know they are low metabolizers, moderate and high metabolizers of folic acid. So in the context of public health intervention, we need to give more doses of folic acid for those low metabolizers, for example. Next. Moving on to the genetic polymorphism on B3 or metabolism, Dr. Rina just discussed a lot about this. And we saw that Dunwoody and colleagues discovered 2 gene variants in humans related to birth defects. And this can replicate effects in mice and also rescue them with niacin supplements. Next. And genetic polymorphism also exists for multiple nutrients and metabolites known to affect pregnancy outcomes. So it is important to make pregnant women know more about their heterogeneity, not only abnormalities in pre and perinatal period. Next. So how do these multiple micronutrient polymorphism may influence the practice of multiple micronutrient supplementation? We can see here on the table that more elements are found in UNIMAP formulation. So UNIMAP is the United Nations International Multiple Macronutrient Antenatal Preparation. And we can see like 13 or 15 elements found in one supplement called MMS, compared to only iron and folic acid in IFA supplements. These more complete elements provided for pregnant women might mean more benefit to women, especially to those who are identified as low metabolizer, as we discussed earlier in the iron folic acid polymorphism genetics relation, especially in LMIC, where the prevalence of anemia in pregnancy is high, they might benefit more. Now, WHO has also updated recommendations on MMS that pregnant women in countries with high prevalence of anemia need to be given MMS instead of EPA alone. In Indonesia, although MMS is not yet nationally implemented, but we can give prioritization for those pregnant women who are identified as anemic or high risk. Next. Yeah, apart from that, so we mentioned earlier, other common risk factors impacting on pregnancy outcomes, such as hypertension, also featured genetic variations that may lead to more precise intervention. It is sequence variants that associate with preeclampsia in the pregnant maternal genome that previously this gene is also established variants for blood pressure. And also it's associated with the gene that is associated with the BMI. So there are 5 maternal preeclampsia variants that have same risk as the gestational hypertension maternal variant. So I will not talk more about this, but we need to talk more about how the advancement in public health to support this blood pressure measurement and monitoring in ANC. I will talk more about this in the next shortly. Next. Okay, I'm stopping here for the first missing piece on daily practice, and we'll move to the second one, the team-based care and technology used to advance ANC, the lesson learned from the field. So as you know, and as I mentioned also before, that SID work is closely related to improving human resource in health, the team-based care approach for an improved antenatal care, delivery and postnatal care service, as well as advanced use of technology. Next. So we believe that these core components that's shown in the slide in a primary care for improved ANC service need to be taken into account and of course need to be implemented. They are active use of data for actions at the point of care, coordinated teams who provide shared care plans among health workers, where these workers will receive incentives based on performance, and to provide or to make the high performance, a continued human resource improvement must be done. Next. Take a look at the current service for pregnant women that you can see on the slide. I think we mostly agree with this because they more on the provider center. So a pregnant woman need to seek health care service to various facilities and various workers, and this pose additional challenge for mothers to get optimized integrated care from the many workers and many facilities, different facilities. Next. So what is ideal actually, as shown in the slide, that where the client or pregnant woman is put in the center of care. As we know that in the context of primary care settings, a pregnant woman is not only tackled or handled by one worker, they will be handled by various workers, namely midwives or bidan, nutritionists, vaccinator, and carer. So they, in this case, if the mother is put in the center of care, they will form a coordinated team-based care. Next. So to create a team-based care that enables them to have pervasive data sharing across workers at the point of care and to use data for action, we need to equip those workers with digital platforms. I will take the example of the use of OpenSRP. OpenSRP stands for Open Smart Register Platform. So this is a digital information system that has been endorsed by the WHO, and it is an open source. So SID is in collaboration with partners, have been developing the Bidan app, the nutrition app, vaccinator app, and early childhood education app that's based on this OpenSRP digital integrated health information system. Next. So this is, you can see that an evidence in the field that when bidans or midwives use the Bidan app alone in the point of care, they shows the improvement in the antenatal care coverage from 75% to over 90%. So the evidence also shows a high compliance on IFA consumption among pregnant women. Next. But when the app is used by all workers who provide service for pregnant women and their babies, the achievement is much higher. We can see this is the network system that we have done already, that from those OpenSRP with different apps get from that handled by all the workers who provide service, antenatal care service for women, they create an achievement even much higher than what previously shown. Next. So here is the model, the different model that adapted into the apps. So on the upper left side, you can see a midwife app. Besides, you can see the vaccinator in the upper right side. Lower left is the ECD worker app, and the lower right is the nutritionist app. All of these are in Bahasa Indonesia, but you can see there is basically a different paper register that normally records during ENC, delivery, and PNC that we made in digital records. So what I want to indicate here is that some of the apps are to update and exchange information between the workers. For instance, you can see here the nutritionist and midwife can have integrated nutritional status data, and the vaccinator can also exchange data for the vaccination. So they are both aware that and can prepare the vaccines timely for the child and pregnant women. Thus, the system provides an ecosystem of network for information between the frontline health workers to provide a coordinated care, so they will know how, what, when, and where to provide services in a real time. Next. So this is the evidence on the match pair study of using the app across workers as an intervention group shows that when only bidan, the green one, you can see the blue one, yeah, when the bidan use the app, there are some significant increase in ANC coverage and reduction in the prevalence of low birth weight compared to baseline. But when the app is used by various workers, the brown graphs, where the various workers, I mean, here is the midwife, nutritionist, and also vaccinator, the result of ANC coverage is even more improving. There is also an increase in PNC coverage and also vaccination coverage. Next. So here is the more detail on the comparison of when the result of the care coverage between control and intervention groups, as I mentioned before. Next. Okay, just click on that. Another lesson from the field is the context of supplementation for pregnant women that is integrated into digital platforms. Here, we introduce a smart supplement that is modified based on client preference involving trained and skilled workers and integrated barcoded supplements with the WHO NC app that is developed based on the WHO NC guidelines. So this integration can help in tracking consumption of MMS. And here is more detailed development of the app and the workflow. So the idea is to develop the smart supplement based on the client preference and also to put barcode on the MMS package that integrated with the current apps deployed in the context of primary health care. So the supplement can be tracked automatically through the apps. Next. So the WHO-NC module, this is the one earlier that the app, actually this is the integration of the narrative recommendation from WHO that is translated into an app. This is called the WHO-NC module. This has been transformed into digital app that has been user tested in Indonesia too, where at the time of the study, actually SID led the study for Indonesia, and here is the publication. This digital module is an open source also, the same as any apps built within the OpenSRP system. So anyone in any country can develop their own app based on their own needs, since the code base and the app development and enhancement can be found on the public domain that's called GitHub. Next.
Ms. Yuni, your turn is 5 minutes left.
Okay, thank you, doctor. The module on the app can guide also the health workers to provide service for pregnant women at the point of care, refer clients for the counseling when, let's say, when the mom is found to be anemic, and further prescribe them with the MMS. So this is the workflow. Next. Let's take a look at the details at the worker using the app. Will register the client first, then do the screening and follow up the 6 modules developed in the app. Next. Then when the mom is found to have anemic, based on the screening result on the app, the worker will be led to MMS prescription. Then the MMS supplement that has been barcoded is instructed to be scanned by the workers for monitoring and tracking for MMS consumption. Next. So apart from the integration of that WHO-NC module with the MMS supplementation, is also there is a further developed to be integrated with optical BP measurement, and SID and partners are currently working on this and will lead the study in Indonesia. As I mentioned earlier, BP monitoring during pregnancy is important and needs to be more advanced, and it is part of standard service during INC. But in fact, many challenges are found to complete this care on routine BP checks, such as we found invalid measurement and limited BP measurement tools and so forth. So this integrated app is intended to be developed and used by workers in low resource settings. Next. And human resource improvement is an integrated part of this overall team-based care and technology use for ANC improvement. So continuous training, coaching, certification is important also, along with human resource improvement and also technology advancement in the context of primary care. Next. So what is the opportunity to put together the missing pieces to improve antenatal care and pregnancy outcomes? Next. In this slide, we can see that now doctors are involved as part of the team-based care for ANC. So doctors can act as a leader to the team and can enhance care for pregnant women. So the role of doctors in primary care is to enhance public health genomics is also crucial. So they can take a part and be the lead for this. And skilled doctors can provide genomic counseling, screening, and even testing to enhance the current public health practice. Next. And of course, the multi-sector approaches are also needed in this case. So to equip health workers with required skills and knowledge, education institution, professional organization, and other stakeholders also play an important role. Let's say to update the SOP for the health workers, provide regulation, certification, and so forth. Next. And to advance this, the role of universal health coverage is also crucial. So payment support for those vulnerable groups to get access to, let's say, for mothers to have more advanced genetic testing can help a lot. So a great paper here by Dr. Rina, published on the Lancet. And we can see from this evidence that actually the lower coverage for healthcare services are found lower among disadvantaged socioeconomic groups. So to promote an equitable access to basic care and more advanced one, we need to accelerate all people getting covered by the universal health coverage. Next. So actually it is a great opportunity for universal health coverage or BPJS if in the near future, BPJS can cover several services that are now mostly out of pocket, such as genomic testing for public health, for advancement, screening, and counseling. Next. So in sum, actually optimal pregnancy outcomes can be reached through public health genomics and precision health approaches, where public health genomics can provide more precise prevention and intervention for vulnerable groups, for example, pregnant women, and must go beyond detection of abnormalities and detect heterogeneities to support action to improve every pregnancy and outcome. And also the current ANC need to be improved more through the team-based care, and technology enables pervasive data sharing and data for actions at the point of care. And skills and knowledge improvement is still also ongoing. So opportunities to take this concept into practice can be achieved. And here we are working closely with our partners, SID works together with GSI Lab, HNRC, IMERI, FKUI, and also other partners to provide a throughput, high throughput, low cost sequencing and genomic services at scale can make this a reality. Yeah, thank you for this. I will close now.
Well, thank you, Ms. Yuni, for your presentation. Sorry for a little extended time. Now we are arriving at the time for questions and answer. And please allow me to read the first question from our colleagues, Dr. Anurat Sankar. These questions for Dr. Rina. What is the best combination of approach and intervention to close the maternal nutritional gap in Indonesia? And also there is a question again from Dr. Devi. How is there any government program that have been implemented to overcome this issue, to close the gap? And when we start this supplementation, should we start to overcome this issue before pregnancy or before women start the reproductive age? This is Dr. Rina, and perhaps Dr. Rima can add to answer this question.
Okay, thank you very much for excellent question from Dr. Anuraj and also Dr. Devi. So I think this is what we found in our study, which also exposed by Dr. Rima and also Yuni. It shows that, especially in our review, yes, shows that there's a big protein gaps between, for example, Indonesia and Malaysian pregnant women. And it's why, and also many are even in both countries and also Asia, why the nutrient intake is very low. So it's actually about the education gap, knowledge gap. So, and at the same time, perhaps also the lower skill set of the frontline health workers to actually improve the knowledge of these pregnant women. So I think this has to be combined together. So how we can do, and what actually mentioned also by Yuni, this is really important to link the nutrition, essential nutrition, to the universal health coverage. So then the budget line for the promotive preventive to increase the behavior change on certain consumption of healthy food, as well as the potential affordable to the good protein sources, and also many other different nutrition sensitive can be overcome by the policy. So nutrition essential has to be included in universal health coverage. So they improve the budget. What the budget now is only less than 10%, 6% of the total budget for health expenditure. So we have to improve that budget in order to increase the potential improvement of program for pregnant women, also lactating women. So I think that's actually on macro level. In my micro level, I think we need to actually improve the social protection and also many subsidy for healthy food for pregnant women, also for vulnerable groups and also for the poor. So for example, can we actually provide the healthy food subsidized by government and increase taxation for unhealthy products? So combine together the subsidy and taxation, which actually can give a better improvement of food environment, especially those who are related to sugar and fat, and as well as the other potential sodium consumption. So I think that's all for a while. And I think to have to apply the technology as mentioned by Uni from SID, I think that's the best way to actually having the adaptable information for the pregnant women as well as for the frontline health workers and improve their capacity. Thank you very much. I think that's all my end. Thank you. Thank you, Dr. Nurul. That's my answer. Hello.
Well, thank you, Dr. Rina, for thank you, Dr. Rina, for your answer. Or perhaps Ms. Yuni, can you answer these questions about the government program to tackle this issue?
Yeah, thank you for the very nice question. Thank you, Dr. Nurul, for forwarding that question. So, yeah, I think our government is also moving towards to the transformation of digital health information system also. And SID is also a close partner with this government partners in the MOH to, let's say, to provide more evidence on how this actually can be implemented in the level of primary healthcare service or in the very primary level. So because we closely with the, let's say, Puskesmas here as the representative of one primary care service in Indonesia, they also really required more digital transformation or more digital transition from the paper-based record, let's say, for the antenatal care. And it also needs actually for helping them to claim their, let's say, the BPJS, because now all of the things come into electronic, and this the system that the digital records in the terms of daily that it used in the point of care, it is also needed for improving the service that they're given to the mother. So actually, Indonesia is now moving towards that, and we will work together to accelerate this to be happen, especially in those low resource area. Even though in a low resource setting, now they are more aware of the need for digital things to be implemented in the context of care service in the primary setting.
Well, thank you, Ms. Yuni, for a nice answer. And the last question for Dr. Rima, there is a question from Dr. Nadia Utami Putri about vitamin D, how long we give vitamin D supplementation from pregnant women, and how about if the pregnant women with hyperemesis gravidarum, is there any recommendation to supply their nutrition in the first semester? Please, Dr. Rima.
Thank you for the question, Dr. Nurul. First of all, I would like to give additional information what Dr. Rina mentioned before, that in spite of education, I think if we look at the publication in Lancet about the availability of nutrients by country in 2013, we know that the availability of some nutrients in Indonesia are very low. For example, zinc, iron, and also find vitamin A. Ideally, the nutrient come from food sources, but in some cases, I think we need supplementation, not only started from early pregnancy, but from preconception. I think that is Dr. Deviana's question. About vitamin D supplementation during pregnancy, I think if we look at the result from Hollis study, we know that the vitamin D 4,000 IU per day, we will achieve the 25 or vitamin D in serum will be achieved 40 nanogram per deciliter. So I think we can give a vitamin D 4,000 international unit per day from first trimester until third trimester or until delivery. If the patient with hyperemesis gravidarum, I think we can give education to the patient, any kind of food that can minimize the emesis, and also we can also give additional medication to the patient to improve the emesis gravidarum. Thank you, Dr. Nurul.
Well, okay. Thank you, Dr. Rima, for a nice answer. Because due to a very limited time, we already extended this time almost 15 minutes. So I will close these sessions, this online conference. Before closing, there is a gap, especially in protein, and we need a special budget for improve good protein source and program to cover this problem. And in the micro level, we have to provide healthy food and allow and also a policy for taxation and a program from government, and we should implement that program for pregnant and lactating women and to digital. There is an information this availability of iron, zinc, and vitamin D due to food availability in Indonesia. And for pregnant women, we can provide 2,000 international unit per day of vitamin D from first trimester until delivery. And for hyperemesis gravidarum, we can educate any kind of food and also supplementation. Thank you very much for interesting presentation, and also all participants. Thank you for this participation. I do apologize if there is any mistakes of me as a moderator for this session. Enjoy in the rest of this weekend, and nice to see you again. Thank you, Dr. Rima, Dr. Rina, and also Miss Yuni. Good afternoon.
Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, ladies and gentlemen. Welcome back to the 6 Eyes on IMERI. Thank you for attending this conference, and we are now on Concurrent session 12, the role of artificial intelligence in infectious disease. Now has joined with us Dr. Ernie Juwita Nelwan, PhD, specialist in internal medicine, tropical infection disease consultant, as the moderator for this concurrent session. Currently, she is the head of tropical and infectious disease division, Department of Internal Medicine, Cipto Mangunkusumo Hospital. Without further ado, please welcome Dr. Ernie Juwita Nelwan, PhD, specialist in internal medicine, tropical infection disease consultant.
Thank you very much, Susma, for the introduction. Ladies and gentlemen, Alhamdulillah, I'm very happy to chair this session in this afternoon. We are going to talk about the artificial intelligence and infectious disease, what is its role. And we have with us now three distinguished speakers. I would like to first start this session and share the time to Dr. Direk Limatu Rotsakul, MSc PhD. Dr. Direk is the Associate Professor in the Department of Tropical Hygiene, Faculty of Tropical Medicine, Mahidol University. He was graduated in 2000 from Chulalongkorn University in Thailand. We are very happy to have him, and I think without further ado, I will share the session to him with the title of the role of artificial intelligence in the battle of antimicrobial resistance. Dr. Direk, time is yours.
Thank you very much, Chair and the committee, for the allowing me to present you about the role of the artificial intelligence with the AMR. If the light doesn't work or if the sound doesn't work, let me know. Okay, I'm going to tell you a bit by starting that, first of all, I'm not an expert in artificial intelligence, and I have been discussing a bit when I was invited to present in this session, but I would like to know that I work on the automated program, which can tell that it's automation and the big data in low and middle income countries. I also have a strong interest and have been preparing to work on the AI, blockchain data sharing, and translational technologies for the low middle income countries. When you have technologies, how can it be used in our setting or in the low middle income countries? This might reduce your hype about the AI a little bit, but I will try to let you know why I think it that way. First of all, as everyone, most of us are medical doctors, I assume. My simple question is that how many days, weeks, or even months for you to generate your local antibiogram? If you are working in a hospital in Indonesia, have you seen antibiogram of your hospital? Have you seen antibiogram of the last year, 2020? What is the percentage of carbapenem-resistant E. coli in your hospital? How many die of carbapenem-resistant E. coli in your hospital? Have you seen that? And as usual, people might want to see it look like in the graph, beautiful, like when you look into the report of World Health Organization glass. And with that, you can be preparing and guiding your antibiotic prescription based on your local antibiogram of your specific hospital. Well, I have to say that in general, many hospitals in Thailand might take about 2 months, 3 months, some maybe longer than that. They might have to send the data to the national authority and wait until the national data come out and they get their local hospital report back. They claim to be a month, but in reality it's like 2 or 3 months. But can we speed up? Everyone has the data in your computer. Most of your laboratory, microbiology laboratory or pathologist laboratory, you have the data in Excel most of the time. Whatever the program you are using, you can export it up. Can you do the generate local antibiogram within 3 minutes? We developed an open access application already published. And my motto is that local first. You shouldn't be able to, you shouldn't have to pass your data to someone to generate the report for you. And most of the time it's about the difficulty of that program. You need to deduplicate the data, match the data with the hospital admission data to generate the report as similar to the WHO class. I will show you the paper already published, the application already open access. By the concept, you can download the program to your computer and you just go to the microbiology laboratory, export your data out as an Excel. If you can, go to hospital admission data center, export the data out in the Excel. Obviously, not every data set have the name or available values in the same way. For example, some hospital might use the word gender. Some hospital may use the word sex. Some hospital may use the word male and female. Some hospital may use 0 and 1 to represent male and female, for example. For that, we know that you don't want to do the difficult programming or stats. So we make everything in the Excel format. Just fill in the Excel form what your variable tell, what your variable define, male, female, for example, and just double click the program. It will generate the PDF report for you within 3 minutes. And it also generates summary Excel file for you if you want to use it. And then you can share the reports immediately. You can share it in your hospital to your doctor. It can be shared to the national authority about the AMR report. And you can share to international in the way of the open access as a report. There is no individual data in the report of the local antibiogram. And if you have hospital admission data, The best thing is that if you have in-hospital mortality, the report can generate the crude mortality report for you. How many die of the AMR for you as well. I would like to try to show you, but I don't think that I have time. So I will move it forward, because if you have time and if you're interested, go to the paper. It's already published. You download the program. We have our video to teach you how it works. But the key point is that local anti-program should make open access. And we already show it for you in these 7 hospitals in 7 countries. And we put into the reference into the paper. You can see that is our fixed share, which you can download the local anti-program. And everyone can see it. Everyone can use it to improve the antibiotics prescription to the patients. Okay, come back a bit. AI, this session is an AI, right? This is the best book that I would say that if you would like to start about the AI in medicine, think about this book. I think it's the best thing. The key about this book is that it talks about all possibilities and all barriers. But the concept is that actually AI should support the doctors to have more quality time with the patients, not the screen time. Just talking to your computer, tack, put everything into a computer. I'm sure that many places use computer in the OPD. Patients start to complain that you don't even look at my face. You just look into the computer all the time and just, okay, finish, you go out of the loop. This is a bit bad, and AI can improve this. But you need to remember first, no data, no AI. Please don't dream that the AI can come to your country immediately if you don't even have the data for the AI to use to train. And I think it is too optimism that if you think that AI generated from the other countries can be immediately used in your country, just copy and paste. It will never work that way. On top of that, that is most terrifying, bad data, bad AI. If your data is biased, if your data is incomplete, what AI algorithm that can tell you is will be horrible. In this book, it have a lot of examples about it. And the good one is about the variables, about EKG and how you use it to diagnose hyper K or atrial fibrillation. If your data is horrible, AI cannot work it out. But once you understand the research methodology, feed the right AI, feed the right concept of the data, AI can solve that. Why? You know that in the low middle income countries about the AMR, if you think about AI to help you by the rich companies to develop the drugs, yes, it might work. But if it's to guide you about the whether you should do blood culture, you should prescribe antibiotics or not, the biggest bias that I know in low middle income countries is that you don't do blood culture enough. And even culture for many for other things, pus, sputum, urine. I show you in one paper that if you use low number of blood culture, what would happen? In the reality, if patients present with a fever, you want to draw blood culture immediately before you give antibiotics. In a week, if they are not improved, or 3 or 4 days, if they are not improved, you repeat blood culture. In my hospital, a 1,000-bed hospital, we do about 70,000 blood cultures per year. In reality, it's about 200 bottles per day. We use that data and we simulate it for you. If we do blood culture less and less and less, what would happen? But we keep all the data as a repeat blood culture into the simulation. This is not AI, this is simulation. Because in the low middle income countries, many doctors just, okay, sepsis, okay, ceftriaxone, 3 days, not better, okay, meropenem. Oh, another 2 days, not better, just add another antibiotic. 7 days, okay, don't die, don't improve, okay, 1 bottle hemoculture. That represents scenarios of doing low and low and low blood culture. What would happen? We know that if you do less and less blood culture, percentage of AMR will be overestimated by the incidence rate. How many cases you have AMR per 100,000 patients or per 1,000 admissions will be underestimated. The issue is just how much. So this is a real data, 100% data from Ubon Ratchathani Hospital in Thailand. Percentage of third generation cephalosporin-resistant E. coli is about 44%. If you split into community origin and hospital origin, based on the WHO glass definition, it looks like this. Incidence rate by definition looks like this. But if you do less and less and less blood culture, the percentage overall of third generation cephaloresistant E. coli could rise up from 44 to 57%. Community origin, by the definition, it doesn't decrease at all, but with wider 95% confidence interval. But hospital origin, if you delay and delay blood culture, the percentage could be so high. So in reality, in many hospitals that you have high percentage of AMR, high percentage of MRSA, high percentage of carbamide-resistant Acinetobacter, it could be because you didn't do blood culture enough. Many patients might not get blood culture since the start of the antibiotics. And the solution, you might be able to present blood culture utilization rate. And another solution that is important is that it might be better in the future if the antibiogram categorized by the timing of the antibiotics. If you split the antibiogram to be among patients who get antibiotic on the first day, the antibiogram will not be changed much, even if you do lower amount of blood culture. But most of the time, even in Thailand, if you split the antibiogram and show only the hospital origin bacteremia that delay outside or failure of empirical treatment, the percentage is high as well. So I found a lot of doctors who misinterpret high percentage of AMR in their hospital, that it's so dirt, it's so bad, AMR is high, so I should give carbapenem to everyone. But actually what you saw is the percentage of AMR among patients who have the failure of empirical antibiotics. And that was bad. So then you should think about it. And I would like to finalize by 2 or 3 things in the future. In the future, this is how it looks like. This is a concept from COVID, but I think it will go for the AMR in Thailand as well. That the left side represents how the clinical data in your hospital, it should be able to transfer the data up to the center in the security way. And then this could be done by even the blockchain technology, so that the security and confidential data still be protected very high. And the AI may run at both center level or the local level. AI is part of it. Deep neural network is part of the AI. This is the future. And I think it will be a long way to go. But if you don't have the local data to even start with, it will be a long road. And obviously barriers are technology, organization, governance barrier. But I think more than anything is cultural barriers. Even if there's an AI tell that by summarize all the data and research in the world, you should give blood culture for every patient who you are going to start parenteral antibiotics in sepsis patients. Even if AI tell you, are you going to change it immediately and now? I doubt it that way. There are a lot of barriers that not even AI say you should wear mask and everyone will wear masks worldwide. Or everyone should have the COVID vaccine now. By the AI, there's still anti-vax worldwide. So the cultural barriers are also important, and you have to understand it and work with it. But the AI is possible, but at the stage, it might still be about the technical stage. And the key is about translation to clinical use, how AI fit it to how you use the data. But we come back to that later. The key that I think about it, not only just AI alone, you need to think about the blockchain, because blockchain is a key about the data sharing in the confidential way and the privacy ownership. And this already launched in 2019, show the example that the pharmaceutical companies already at least 10 steps ahead from the hospitals in the low middle income country. They start sharing the data and they use a blockchain so that the blockchain can supplement the AI for that. And you can look into this paper later if you're interested in. But I think I might run over time, so I will come back to the basic thing, so that you have to remember first, no data, no AI. If you want the AI to come to help patients and doctors in your local areas, it should start by making the data available. Most of the time, it's run by, you have the data first, you automate it, you analyze it, and you make the data open access. And then you can go to the step of the AI. If you cannot make the data available in your hand, you don't have to share it to other people. You need to analyze it. You can analyze it faster with automation, and then you can report or publish the report in the open access way. I already show it with the anti-program of 7 countries. Then that's the next step before you go to the AI. So for the AMR, for the low middle income countries, before the AI, I think we should start by making local antibiograms of every hospital in low and middle income countries available now and as fast as possible. You don't need to know stat. You can use the application to help you. And you don't need to transfer the data. You don't need to call me. You can just look into that. There are many ways to help you make it happen. And not only have the antibiogram in your hospital, you should make it open access. And we should promote it. You shouldn't penalize them if they make antibiogram open access. That's the good way to go. And the WHO support it. The new document also support it. And you should learn from the local antibiograms to help guiding the antibiotics properly. Don't use it wrongly by misunderstand about you are not using culture enough. I always think, do we underuse blood culture? Do we misuse it? And do you overuse antibiotics in your hospital? And then bad data, bad AI. So you have to prepare for this before you jump for the AI to help you about new antibiotics, culture, antibiotic prescription. And that's all for me. Thank you very much.
Thank you very much, Dr. Direk. Very clear and easy to follow. I think for many of us, artificial intelligence is like a new topics, and we are very keen to know about this. And I think the presentation just now helped very much to start, and then later on we can get ourselves masters on it. Thank you, and you save time for the next speakers. I would like now to welcome Dr. Suwarti. Yeah, we used to call her Ati. Dr. Ati is the postdoctoral fellow, University of Indonesia, Oxford Clinical Research Laboratory, Eijkman Oxford Clinical Research Unit, and also the adjunct researchers in Infectious Disease and Immunology Research Cluster in IMERI FKUI. She graduated from Bogor Agricultural in Bogor, and I would like now to give the time to Dr. Suwarti with the title focusing on artificial intelligence in tuberculosis. Please, Wati, time is yours.
Okay, thank you, Dr. Ernie. Good afternoon, everyone. It is an honor to be here. Please let me know if my voice is not working in a way. So I need to claim exactly the same as what Dr. Derek would claim, that I'm not an artificial intelligence, but now I'm currently using a few tuberculosis diagnostic research, and it has been an honor for me to share these presentations to everyone. Okay, I don't think. Please, I will try to have, it didn't. Can everybody see in the slide?
Can you make it bigger, please?
Okay, wait a minute.
Maybe the committee can help because it's not in a full screen format yet just now.
Yeah. Okay. I hope it worked now. Does it working?
Yes, excellent. Please go ahead.
Okay, so sorry. So the AI has developed rapidly for the last half of the centuries, then it creates the intelligence evolutions, and we are who's working in the health services might want to have another beneficiaries from this AI. So we hope that the artificial intelligence will improve the health services that could create the global health equality. As we know that currently the situations might lead to the acute health workforce shortages. Moreover, in this pandemic time, we lost a lot of people working in the healthcare sectors. And we know there are a huge gap in the weak public health surveillance system. Probably this is also one of the cause the pandemic is devastating. Of course, everybody's not predicting about that. So the AI-driven health interventions can fit into 4 categories that related to global health researches. The first one might be the diagnostic, the patient's morbidity or mortality risk assessment, and we hope that the AI could also predict the disease outbreak and surveillance, and then can create the health policy and good planning system. So these are the examples of how the AI currently being investigated in many healthcare sectors. These 2 papers are published from the deep learning computer software that remark their milestone by combating a human intelligence in an online game. So the first one is they're trying to use the AI to predict the future acute kidney injury. They claim that it can reduce 48 hours to predict what happened to the people with the AKI faster for the physicians to determine. And the other one is also trying to apply the diagnostics for any abnormalities in the retinal diseases. So it also happened that this AI might convert the tuberculosis challenges. As we know, these diseases as one of the top 10 causes that worldwide infectious disease. Currently, more than 10 million people are infected with tuberculosis, and perhaps the pandemic might increase the number, because it is estimated that we are getting a step back another 20 to 30 years because of this pandemic for tuberculosis program. So these are the obstacles that happened in the determinations of tuberculosis infections. Most of the diagnosis came from the sputum samples, especially for those who had the TB pulmonary. They are analyzed by specimen collections under microscopic that could be a time sensitive, human skill sensitive. Another gold standard that everybody is using is to grow the tuberculosis itself in the biosafety level 3 containment. However, many low middle income countries do not have those facilities. So this is another obstacles. The other one is using this gene expert MTB rifampicinases. This is worldwide distributed and now even currently used for COVID-19 diagnostic. But as we know that a single or a centralized diagnostic system might not answer the global needs of diagnostic. And we should notice that until now, we only have 1 vaccines for the TB that already 100 years old age, that only BCG. So physicians were helped to diagnose the tuberculosis based on the chest X-ray. However, as I noted there are quite numerous challenges that if physicians use the chest X-ray for tuberculosis diagnostic. One of those might coming from the intra-reader and intra-reader variability. So it highly depend on how the radiologist examine the X-ray. More or less, we don't know how good the quality that X-rays is being used. And we need to have a good archiving repository system to compile those X-ray data. So currently, thanks to the technology development, now there are a lot of tools that lower the operational costs, increasing the image quality of the X-ray, digitizations, the archiving process, and even lower down the ionizing radiations of X-ray for the diagnostic. Until 2020, March 2020, WHO recommend the use of the X-ray for the tuberculosis diagnostic, mostly to screen everybody would have a presumptive TB, or those TB in childhood or pediatricians, or those who are living with the HIV, or we can even rule out those X-ray diagnostic from latent TB. And as many of us might know, the Gene Expert is one of the tremendous molecular tests that being used for TB diagnostic. But we know that this is also a highly cost for LMIC. So hopefully the CX-ray tuberculosis diagnostic can improve the efficiency of those molecular test usage. However, this remain limit the access for having the high diagnostic quality digital image of X-ray, and then we are still lacking of the shortage trained readers to interpret the images. So here is what happened for the last 20 years. Many researchers trying to develop the help of artificial intelligence to implement TB CX-ray by using the computer-aided detections through the machine learning. You are compiling many subset of X-ray from the patients, and then researchers trying to use a deep learning when you try to build layer by layer to connect those data to divine the TB diagnostic. These are the examples of one of the software that developed named Genki. It claimed that it can distinguish the TB suspect and any potential COVID-19 suspect and other pathologies from the abnormalities of the TB, abnormalities of the X-ray. So these are coming from many studies that currently already been applied for the last 20 years. Here are the examples of those software. One of the software that quite having tremendous development, it's already in the market currently, called computer-aided detections for tuberculosis. As you see, these are the compiled data sets of the patients, and then you can have seen the scoring system of what kind of a X-ray represents in this by those patients using the artificial intelligence through the neural network that created by the software. And the column here, CAT4TB7, this is the name of the software. You can see there are a lot of number of scoring system. So what happened if you have, for example, in the left side, you have low number of the CAT-TB7s, and you have the patients and coming with the admitted with the symptoms that specifically for TB, fever, cough, or night sweats, and then you can compare that directly to the X-ray. The lower CAT4TB scoring showing that the lower probability of the patients develop an active TB. If you compare that to the higher Cat4 TB score, then you can see the abnormalities progressing to a TB directly. So actually, these things are already developed for more than 10 years. And one of the papers that remark the beneficiaries of using the software compared to the human reader is these are one of the examples that they were claiming these 5 software engineer create a better readout compared to the human reading in the CX array. So, and then it also claimed that the sensitivities is quite high. Another point of view that also we will have from having artificial intelligence is they reduce the molecular tests. For example, they're claiming that the sensitivity can reduce the expert test used. As we know that if it's already been confirmed that we can try to reduce the test for expert use. However, I agree with what Dr. Derek said. The data might coming from a different geographical settings. So probably the studies should be more developed. Where do you get the data to build the neural network system? Let's say if you find that from African sub-Saharan countries, the pathologies might be different from what we have in Asian, that mostly we are Southeast Asia countries having a pulmonary TB compared to sub-Saharan that have a TB with HIV. So it is advisable also to have your own data to create those neural network system efficiently. So here are the computer-aided systems that currently being developed or applied in the market. This is only half of them. You can notice that there are a lot of certifications there, whether they already been FDA approved or CE mark, or they are still pending. And we can see also the development stage, whether it already been validated, whether it is on the market, or they are still trying to see this to compile the data from their study. So this is how the software was created. I compare one of the 3 examples, trying to they create a different targeted intended age group. They create a different system of where this software can be applied, whether we can use it in primary health care, the national TB program sectors, or even in the private sectors. And it is also, we can compare that the data, the neural network, the software system that they use was developed on 1,000 or even 100 to million chest X-ray from over several countries. So here what it might look like currently for the implementations of CX-ray for tuberculosis screening. If we have the facilities-based imaging, then we can have the X-ray directly, or you can have the mobile system. Or if you are not the facility-based imaging, then you can use the mobile system only. You can use it in the rural or urban, or it depends on where the populations that we want to use. How about in Indonesia? Currently, the software system is used for the screening for tuberculosis in some populated settings. Here are the examples of how the Cat4 TB system used in the prisons for screening TB there. So, however, in Indonesia, we are still lack of the studies to validate the use of this software system, that Cat4 TB screening. I came up to the conclusions that we will still have a lot of challenges to implement this AI. First, we still need the subsequent confirmatory testing, because we could not diagnose tuberculosis based on the AI only, but we need to do the bacteriologically confirmed or a proven clinically confirmed. And it should be a clear definitions on the computer-aided detection for defining active TB cases. This is where the case where when we have a good data to define the active TB cases, then we will have a good standard with a CAD for a high sensitivity for TB diagnostic. And apparently it's still having a high software cost. And then we need to have, maybe the ideal way is to have the sensitivity comparisons, not only to the human reader, but we need that to have comparisons to the reference test. It might be not apple to apple, but we hope that the future development technologies can improve such a way the AI to create those conditions. I think that's all for my talk. Thank you so much.
Thank you, Bu Ati, for the presentation. Yes, very happy now we have another example of artificial intelligence that already been used to diagnose the most challenges diseases like tuberculosis, and also it's been also applied in Indonesia. And we'll be hearing the third speaker. Very happy to have Dr. Joe. Yes, so this is the CV. Dr. Joseph Robert Fiches is the Senior Advisor for Special Projects at the Institute Pasteur de Dakar, Senegal. And yeah, he got a lot of trainings, as you can see here, and he will be talk to us about digitally enabled RDT for event-based surveillance of outbreak-prone infectious diseases. So this is another example that we are going to learn this evening. And Dr. Joe, the time is yours, please.
Dr. Ernie, thank you very much for the invitation to speak. Apologies, I'll keep the camera off. As you saw briefly, it's dark here in Senegal. It's just morning time and the sun is rising. And I'm here to talk to you about digitally enabled rapid diagnostic tests, DRDTs, and whether they represent the future of event-based surveillance for outbreak-prone infectious diseases. A quick note on the Institut Pasteur de Dakar. It's a Senegalese public health foundation. It's 97 years in Senegal. And in 1924, the eldest building of the campus has now been converted into a yellow fever vaccine manufacturing facility, which is one of the key areas of expertise here in Dakar. It's part of the International Institut Pasteur network, which is 32 institutes around the world and many in East and Southeast Asia, which you may be familiar with, and of 5 in West Africa and 1 in Madagascar. One of the key areas around innovation has been diagnostics and thinking about the future of diagnostics. And it was great to hear in the last talk the importance of computer-assisted diagnostics and the role of technology and how it can play an important role in lower income settings like Senegal. And until this point, here are some of the other areas Institut Pasteur de Dakar have been contributing to. The one on the left is a suitcase which was key for the portable PCR and diagnostics for the Ebola outbreak. In the middle, it's the mobile laboratories, which can drive across some very difficult terrain. And on the right is smart sample sensing, so keeping track of information, location, temperature, and other important factors of precious samples that come out from the field to the central laboratory in Dakar. One last note about the institute. On the left, you can see the yellow fever vaccine has been produced with WHO requirements for 80 years. Since 1967, it's been WHO pre-qualified. And this coming year, we have the expansion through the Africa Amaril project for yellow fever, but also not in this image, in the building that is adjacent to it that's being built is the COVID-19 Madiba facility. So an opportunity here to really think about how to bring next generation technologies to settings that have less healthcare resources than some of the higher income countries. So turning now to digitally enabled RDTs and diagnostics in general, we turn really first to the backbone of our surveillance system and how data science and artificial intelligence have been layered on top of this. It really started back in '96 with the influenza surveillance in Dakar. But as you can see, it took over 15 years to strengthen even that surveillance and add influenza-like illness and surveillance data in the community. This very quickly, however, a backbone of the community care surveillance network allowed for the surveillance of other acute syndromes, malaria, arboviruses, diarrheal disease, and other respiratory viruses, RSV, coronaviruses, and outbreak-prone pathogens. So that extension in 2012 is a really important moment. In 2015, the severe acute respiratory illness surveillance in hospitals began. And as you can see, that's really helped Senegal with COVID-19 because this allowed us to have information very quickly from both the community and the hospital settings to guide our COVID response. And lastly, in the last 4 years, antimicrobial resistance has been integrated as part of a One Health approach. And we call this 4S, the Senegalese Sentinel Syndromic Surveillance System. It should really have 5 S's, but there we go. Here are where the sites are. This is Senegal. I'm based just next to the dot where it says Umbour on the left, on the coast, and further up where the red H's are is Dakar, the capital. And you can see that there are sites such as Kédougou, southeast, which border with Mali, close to the Gambia, and Guinea-Bissau. And these are really important surveillance sites. And these are close geographically to the sites in Guinea, for example, where Marburg and Ebola have recently been detected multiple times. So very important to have a surveillance system in place. Now, it's also 2 days drive to get from Dakar to Kédougou, which I appreciate is nothing for the 17,000 islands in Indonesia and other island settings in Southeast Asia. But we really need to make sure that in those 2 days, we can shorten that as much as possible because of the logistics required in the laboratory confirmation. And so digital RDTs and sensing, which I'll come to, I think will play a very important role in the new surveillance system that's being expanded to 79 sites in each district of Senegal, based on this. Here are some of the detections, important detections just last year in different cities. So March 2020 was the index case of COVID-19, early March. July in the same city for yellow fever. Another city we picked up the dengue outbreak circulating. West Nile, Rift Valley fever, Congo Crimean hemorrhagic fever, very important outbreak-prone infections that we must control quickly, and Kédougou. And you can see that Kédougou, dengue, yellow fever, and chikungunya in that remotest of sites were picked up this year, last year in November 2020. And here shows the intersection between the different areas of expertise that you need. And this is where artificial intelligence will come through as more data feeds in to the system. So here, traditional sensing on the left with epidemiological data, breaching the barrier of what we would expect seasonally with the noise. the mobile labs that are sent straight away if we believe there is a challenge in a setting that doesn't have access to high quality laboratories, and we don't think we can wait to send to Dakar. The gentleman on the bottom left is Dr. Sheikh Tidiane Diagne. I'll come back to him and his role soon, but you can see him working in the mobile laboratory in the middle. And on the right, bottom right, is our director, Amadou Sal, in France for a meeting, receiving the data in real time. It's a very important backbone of the Sentinel surveillance system that needs strengthening. And we can do that with the digitization. So turning to event-based surveillance and indicator-based surveillance, they are very different, but both very important. And digital RDTs, DRDTs, really can play an important role in event-based surveillance, but they almost bridge and blur the lines between the two, because you'll be engaging healthcare workers with indicator-based surveillance, and you'll often have a patient in front of you or near you, or contactable. However, we focus on the event-based surveillance role for DRDTs because just taking one RDT can allow you to have the potential to send a signal that there could be an outbreak. So let's take the example of malaria. Malaria is very common in this region, but it is looking to be eliminated in the north. So having positive tests in the north of the country allows you to guide public health efforts, because we shouldn't be seeing them. So it allows you to signal an event of a possible outbreak. In the south, there's a lot of malaria which is seasonal. So outside the season, it allows you to come into action if it's slightly earlier or extending slightly later than you would expect. And so just having one digitally enabled rapid test allows you to make substantial and important public health measures. The other piece to note is most people here do get a malaria test because it's endemic, even if seasonally it's not all year round a major burden. Now, having a boost in just negative rapid tests in a cluster also signals an event, because what it tells you is there's an acute fever. And it tells you there's an acute fever that's malaria negative. And so that again is a signal that allows us to go and investigate whether it's dengue or yellow fever or something else. Critically important for the future of surveillance. And the research methodology we are looking at the moment as to how we design and improve this network is as follows, thanks to our partners Lightful in the United Kingdom, really going through a discovery phase to make sure we really learn about which users in the wider context, because this adds a step. It adds a photograph, or it adds use with the reader, or in its most basic form, it needs healthcare workers to take the time to complete the data sets which are on their tablets in this setting. So we really need to make sure it's as easy as possible and that the data is as useful as possible for the science team back in Dakar. The challenges need to be defined. I think I try to touch on that with the examples of simplicity around how event-based surveillance can be so useful. Another example is of event-based surveillance might be a teacher who notices that half the classroom are not coming in for a week, signaling there might be something wrong in the community with illness. And so these are very important challenges that must converge. And then we can then come up with the right ideas and then evaluate those ideas to make sure we have the most simple and robust system possible. This is really the very basic, but what we expect it would look like. This is what we have already on our, what we call Teranga digital system. So the principles are to initiate access, either from a self-test, if it's COVID or HIV or another test, or a clinician-led test, has to be extremely low cost. As the last speakers have mentioned very clearly, there are some great technologies out there. They are just not made for these settings at the right price when they could be better and cheaper. The test needs to be administered, and then we interpret, and we're agnostic to how the interpretation is captured. Mobile phone, tablet, visual, or at the bottom left, you can see is a reader. We work very closely with the Igloo reader out of Germany, and we work very closely with many software companies. We have our own team, but in particular one called Ordere out of Seattle. And then that process is able to then be standardized. And if we can standardize the process of that capture and store it, over time, that allows you the privilege to act on it for the public health purposes. So how deep is the evidence base? Well, it is growing. It is only really recent years that I think people have been trying to see what is possible with digital RDTs. It's much more focused on radiology and other aspects of diagnostics in the laboratory. But how long will it be until we can access these technologies at point of need? And that is crucial. Well, a start has been made by the Foundation for Innovative New Diagnostics. On the next slide, you'll see the criteria have been set for an application that allows for surveillance of outbreak-prone infectious diseases. Hopefully that slide will be with you just shortly. And for HIV, what we see is an infographic here from the team that published out of South Africa in Nature Medicine around endemic diseases, pandemics like HIV that are established, that will always need, until their true control, digitization and records of care, records of tests. This algorithm allows you, through that secure database, to improve staff training, improve stock supply management, laboratory information systems, quality control, surveillance, and linkage to care. The benefits are many. The cost has been prohibitive to date. Few people have worked on how to reduce that cost. However, through COVID, what we hope a legacy can be is the value of a digital result, and the fact that every drug or every vaccine or every diagnostic really needs to be recorded. These are interventions. They at least need to be documented. I mean, if we can base it on that principle, as we do with handwritten notes in a hospital, then I think we can make real progress in this space and reduce the price. Here, just very quickly, I won't go into detail, but it shows all of the characteristics of the target product profile that have been considered. And target product profiles always are a strange process. They're obviously very aspirational, wanting the best performance for the lowest cost for the most use. But if you get a target product profile right, it can be very, very helpful. But here you can see, whilst the interpretation of this paper is that everything's green and everything's a great agreement, I actually look at the dark blue, which says fully agree, rather than light blue, mostly agree. And you can see huge variability. I'm not sure that we have got these target product profiles right. And certainly what I would urge is that different groups, like groups in your settings and our settings, come together to share what we've done and what we're doing, like we are now. So you can see what might be useful elsewhere and what principles can be guiding the future of digital rapid RDTs and their potential, particularly in low-income settings without many labs and hospitals to help. Here are the areas that we're looking at in Senegal, and we're actually looking to produce these in our manufacturing site. So Institut Pasteur de Dakar has a vaccine manufacturing site, but it's also launched last year a rapid diagnostic manufacturing site, so that you can combine both your research your surveillance, then ultimately your manufacturing and access. You can see what you need. And in our case, we need dengue tests. Dengue is often thought about as a challenge in Southeast Asia, South Asia, Brazil, Latin America, but there's a lot of dengue in Africa. And every year in Senegal, we have outbreaks now that have left the capital into other major cities. And I've just been bitten, I think, by a good 5 mosquitoes during this talk already. And they look like they could transmit dengue. So tuberculosis and HIV are the established pandemics, but also emerging pandemics need this system in particular, either now widespread like COVID-19, still require this surveillance, particularly in areas with lower immunization rates. We have about 6% in Senegal, which we need to boost as high as possible. And other things like Congo Crimean hemorrhagic fever, which I mentioned, low volume, sporadic, but very, very severe if you get it. We need to detect it as soon as possible. And of course, NTDs and vaccine preventable diseases too. Two quick slides conceptually on how the system will work. It's going to be a risk-based system to layer on to the Teranga network you've seen before. And it'll be guided to begin with the diagnostics we produce ourselves. So here, yellow fever, measles, COVID, and malaria are due for different pilots. And on the next slide, you'll see the value of having local data as well with sensors. So installing temperature, mosquito traps, and other factors around temperature, around rainfall, which may not directly lead to health impact. However, what they do is signal a different behavior that might follow in the community. It might signal more mosquitoes for the coming week or two. And these, of course, are all associated with worse health outcomes in these communities. So it allows you to guide your limited resources to those settings and prevent further spread. And here, using the Kedugu example of environmental sensors, seeing where more mosquitoes may have been detected versus areas with less. So just to complete the talk, wanted to talk to you about the Diatropics manufacturing facility. So at Diatropics, we have a small, medium volume production site up to 10 million rapid tests a year, scaling up right now to 50 to 60 million. And the idea is that these are tests where there are none available in the region. And arguably, you could say COVID rapid tests were not available in this region, certainly at the beginning, because they were too expensive. When tests are available, they need to make sure they're satisfactory in their performance and quality first. And if they are satisfactory in their performance and quality, but they are not affordable, then we kick in as well to launch the new tests that are needed. Thank you. The slides seem to have disappeared, but that might be my time is up. So thank you very much for the attention. Happy to take further questions.
Yes, thank you very much, Joe, for the presentation. It's open our eyes here that even in the remote setting with the limitation in geographics and also capacity to making diagnosis, the role of artificial intelligence seems to have important impact. Joe, there's a question for you. I will start the Q&A now. We have still now around 9 minutes for the question and answer. The question is, in infectious disease, the most important for the doctors is actually to know what is the cause of the illnesses. And is it possible for AI replacing the role of medical doctors in the future in terms of diagnosing disease? There's a one question, of course, from the audience. Please.
It's a great question. So to talk about DRDTs, at the moment, the performance of some tests cannot replace laboratory confirmation, and for others, they can in certain settings. And so here the backbone, of course, of testing is RDTs for malaria, and that's what we use to treat malaria and guide the treatment. But in reality, some people are treated empirically with antibiotics or antimalarials in this setting. And so one way for artificial intelligence to play a role in the future, and something we're wanting to pilot now with pharmacies, is looking to the small pharmacies right up in the community where there might not be a doctor, and ensure that those pharmacies have access to the DRTDs. And then the RDTs will allow you to know that the quality is high, so you can be more confident in the performance. It allows you to, if it's positive, link for health payment to a health wallet, which are becoming more common in this region on mobile phones. And it allows you to subsidize or pay for the treatment necessary so that the pharmacist can administer that treatment. So really looking to see what can technology and AI offer so that even in interpretation one day of these lines is possible. And that program is supported by the Gates Foundation. One last point on the future of that technology, there are other technologies that don't exist yet, but are in the pipeline at the moment, which are electrochemical. And so they are digital and electrochemical, and you don't see the result. It's all done within the device. And so think of it a bit as a contactless credit card. When you place it on a device or next to your phone, after 5-10 minutes, whatever the time needed to run the test, if it's positive, it'll send a certain signal to your phone that it's positive, and if it's negative or invalid, it will do a different signal. And this is very, very important in the world of AI, where, of course, you can't replace the clinicians, but you can offer an aid with next generation technology and hopefully link more people to care.
Okay, thank you, Joe. So we are now see the next question. I would like to address this to Dr. Jirek. What do you think the biggest challenge of the use of AI in diagnosing for example, the antimicrobial resistance or other infectious disease problem, in particular in Asia, Southeast Asia country, or in a country like Indonesia or Thailand? Can you have comments on this, please?
Sorry, can I repeat the question a bit? Whether it's about AI or barrier in general?
Yes. The challenges in implementing or starting to have the AI in a country like us in Indonesia or in Thailand, maybe compared to another setting in the Europe or in the US, please.
Yeah, I think it's a combination of the costing, culture, organization, behavior of doctors. But if you think overall, what are the biggest? I think cultural barriers seem to be biggest to me. I think I saw quite a number of the AI coming. I saw both like a chest X-ray assisting imaging, reading, assisting IDT electrochemical in the pipeline. But then to implement it, what you need is the political support, organizational support, doctor society support, patient society, NGO support. If it's not strong enough, it's quite difficult to implement it. And in lower middle income countries, it's easy for government or Ministry of Health do the same, stay the same, keep the norm or keep the culture stable. They don't want to rock the boat. So to push it, you need the overwhelming support from all people rely to it. it's not really just a costing alone. And I feel that to get the biggest support, you need to move all organizations, doctor society, government, patients, NGO together and push for it. That I think is the most difficult one. For example, one of my work is to improve doctors to order blood culture in low and middle income countries. I already proved it. That it's not about money. Many hospitals in Africa, in Asia, there are hospitals that even promote it to be for free. But doctors still don't feel comfortable or don't feel easy to order it as much as it should be by the international recommendation. So that stuck it. Even go to the level of the implementation, even just the cultural behavior is still difficult. So technology is one thing, human thing is one thing, and I think that it needs a lot of work to go together. Over.
Okay, yeah. So it's also needs whether the doctors or the humans want to change to support all the technology that will come towards us and to give the next benefit for us in working with patients. Thank you, Dr. Direk, for sharing that with us. I have another question. Maybe Ibu Ati can share her experience in tuberculosis. You mentioned that the rate of the chest X-ray for tuberculosis patient using the program seems more is far better compared to the human reading. Is that one of your slides showing that? Can you elaborate more about that?
Thank you, Dr. Ernie. So several studies already prove that the artificial intelligence might beat the readout from the expert, let's say from the radiologist, to distinguish those TB X-ray abnormalities from presumptive TB patients. However, need to remind that it depends on what kind of the data generated to create the neural network itself. I mean, if we're collecting the data from the subsets that mostly dominated with TB HIV, then we compare that for, let's say, Indonesian people who had a very high smoking rate. We cannot distinguish whether the abnormalities coming from the TB itself or the severity that causing by the behavior of the patients that highly dominated with the smoking habits. So although it surpasses many of the human readout, we still need to do a validation and in the specific geographical settings to get the clear whether those are site specific or we can generate that generally. I think that's all.
Yes, thank you very much, Ibu Ati. Do we have any question, more question from the audience? Let me check first. Okay, it's not there yet. So maybe we are about to come to the end of the session, but is it possible for me to have like simple remarks for each speakers about their view on artificial intelligence in infectious disease, in particular in a difficult setting like a country in Asia or in Africa, to help improve our patient care, to improve the outcome of the case management in patient in any example of disease, can be tuberculosis, HIV, or antimicrobial resistance as one of the problem now in the world. May I start from Dr. Direk, please?
Thank you. Thank you. I think from today, I hope that you have some vision on the artificial intelligence. I think that from the basic, I think if you read many things, you need to know that at the moment, AI is good with pattern to detect pattern. So that's why something in the pictures like a chest X-ray or something in the deep text, like if all of the case records of the patients are in the text, in the digitized format, it can do deep mining of the text, searching, analyze it. With those two things, it makes artificial intelligence quite strong to provide some guidance to support doctor. The second thing that I think is good to know is that it's unlikely that AI will replace doctor 100%. It's likely that AI will be used to support doctor. Doctor roles may shift it a bit more to have time to talk with the patients. It should be that way. And AI assist the diagnosis. AI assist the treatment to remind you, you should do this, to remind you that this case may be more likely to be TB. Those are the common way of how AI is moving. And I think that if, let's say, because we are in Indonesia, I think if you would like more AI to be fast, to move quick in Indonesia, I think the local organization will have to work out a way so that the research and testing can be faster. The data security and data confidentiality is very important. I totally agree. I totally understand. But you should be able to do it within the research in your organization and then keep the balance between confidentiality and testing and develop your own data for the AI that can be useful for the local patients. I think that the key is no data, no AI, bad data, bad AI. And if you don't do anything in your local, no local benefit at all. So those are three things that you should keep in mind from me as a basic. Over.
Thank you, Dr. Direk, for inviting that message again. So we start to now need to, carefully collect our data to be later on prepare our role in using the artificial intelligence to support our works in working with patients. Next, Iwati, please, can you highlight the remarks for the audience regarding the talks today?
Okay, it is quite huge thunderstorm raining here in my place, so you might hear the thunder back sound. I will not go for long sentences, but we hope to see that these AI development can generate the equality for a global health in any kind of settings. So where we don't have the healthcare workers provided in and distributed equally, we hope that AI can support that as much as we can, especially in Indonesia, from east to west, north to south, that had thousands of islands. So we hope the future can bring us to the equality of the health for all of the people in the world. Thank you.
Thank you, Buati. So the last time we'll give to Joe, because I think we are now about the time that we need to stop. Joe, please, can you share your remarks on the meetings?
Yes, just to build on these two remarks, I'd say that what we'll see hopefully in the future is that support, the pattern recognition with difficult, faint lines on rapid tests needs support. They're faint and difficult to read. And so if we have a technology that can support that through image analysis, then that's something very valuable. And then it's up to the regulators to decide how you use that information. And one way our partners has used their AI is to have a nudge or a "are you sure" check. So if you as the doctor or the clinician look at the test and say it's negative, but the computer thinks it's different, it'll ask you, are you sure? And the data so far that we've seen on that has been superior performance from the AI on those very difficult lines. So I'll leave you with that example of where it can help in the future.
Okay, thanks very much, Joe. I think I'm not going to make any summary for the meetings, but as a clinicians or people working in the lab, we need to know or makes ourselves get involved with technology to support our works in general, of course, to do diagnostic in patient, to help our patient in infectious disease in particular. I think I need to stop now. Thank you very much for all speakers and also the committee that shared the session for us from the Infectious Disease and Immunology Research Center, IDRC, and I will give the time back to the committee.
Warahmatullahi wabarakatuh. Good afternoon, ladies and gentlemen. For our last but not least agenda for today, we have two sessions happening in Hall A and also Hall B. And we have concurrent session 14 with the topic probiotic and gut-lung axis. While we're waiting for Prof. Murdani as our moderator, we have also Professor Dr. Anurag Shankar from Oxford University to moderate our session. Let us welcome Professor Dr. Anurag Shankar. Time is yours.
Okay, yeah, thank you so much. I'm happy to step in and do some hosting here. Are you able to hear me?
Yes, clearly, Prof.
Okay, great. Okay, yeah. So yeah, I'm happy to step in. I think this is a very exciting session that we're going to be hearing today, really about issues around the probiotics, important of this, really important to this overall during the pandemic. So I think we're a little bit delayed, so let's go ahead and get started. So first I'd like to introduce Professor Diego Peroni from the University of Pisa in Italy. Dr. Rina Agostina, are you ready to go? Are you prepared to go ahead?
Okay.
Okay, yeah. Excellent. So yeah, let me just say, Dr. Rina Agostina has done really extensive work in probiotics. She's one of the top researchers really in the world, and certainly in Indonesia, about health and nutrition. She's the head of the Human Nutrition Research Center at the Indonesian Medical Education Research Institute. So over to you, Dr. Agostina, and I know you have some always doing some very exciting work, and we're happy to hear from you today.
Thank you very much, Dr. Anurag Shankar. I would like to thank the organizing committee for inviting me today. Also welcome to all participants, especially to Dr. Marcella Simadidata and also Professor Diego. And Assalamualaikum warahmatullahi wabarakatuh. As mentioned, I am actually from the Department of Nutrition, Human Nutrition Center, Indonesian Medical Education and Research Institute, Faculty of Medicine, University of Indonesia. Here, I would like to take a chance to discuss about the roles of probiotics and micronutrients on gut-lung axis. So first, I would like to congratulate everyone because you are all super. We are all, as a human being, is super organism. Our body is colonized by a large number of microbial communities, and the omic assessment shows that our body consists of human genomes and with microbial metagenome that encode diverse function and pathway and provide metabolites and signaling molecules essential for host survival and development. And if we see here, on the other hand, our food, our intake, the diet that we consume can influence our nutritional status and directly impact pathogenesis of malnutrition and inflammation, for example, of fueling host metabolism. However, recent evidence showing that nutrition is also a main environmental factor shaping the composition and function of the microbiome. So here we would like to discuss about this and how this nutrient influence the microbial metabolites and also inflammation as well as the infection. So and now because of this interaction between the microbes to microbes or microbes to the host, it's been recognized that the modulation and restoration of the gut microbiota can be used as the management of several gastrointestinal disorders. So this has already been long studied with many various type of studies in developed countries. There are 4 therapeutic strategies or management such as prebiotics, probiotics, postbiotics treatment, or fecal microbiota transplantation. These actually all gain popularity. And there's also now, it's not only related to the intestinal organ, but there's a growing appreciation of the role of gut microbiota and in all aspects of health and disease, including the brain as the gut-brain axis and the lung axis and the immunity as well as the skin. So let's firstly see on the efficacy of probiotics. Without actually seeing that a lot of accumulating evidence showing that the prevention of bacterial and viral infection, including gastroenteritis, sepsis, and respiratory tract infection, and the best clinical evidence, we know that treatment of acute gastroenteritis in children, especially rotaviral, and we see also on antibiotic-associated diarrhea, both in children and adults, and also necrolytic enterocolitis. This actually been very much showing in many studies and none until now directly on etiology agent of COVID-19 pandemic. So I would like to first share our studies on the how the effect of probiotics on the gut health. So this here, we actually did the study, included a screen almost 4,000 children and randomly assigned about 494 children aged 1 to 6 years. And we actually randomly allocated into low calcium milk, regular calcium milk, and regular calcium milk plus with lactobacillus casei 431, and the other one, DSM 179398. So, and this actually then been intervened for 6 months period. And what we found actually on our main outcomes that we published in Pediatrics, showing that the intervention of these 4 different types, showing that on the reuteri, on the probiotics, especially on the reuteri group, showing both the all-reported diarrhea as well as the WHO-defined diarrhea, a reduction of about 32% on all-reported diarrhea and 24% in WHO-defined diarrhea on incidence of diarrhea, especially on the reuteri group. And this actually also particularly strong effect in children with lower nutritional status. And then we follow also, we also look at the other outcomes and showing that the group time-specific changes in height for age and weight for HC score, where the children actually grow normally. But if you look at here on this 7938 actually grow better, especially on weight for HC score and weight gain. And although we do not find acute respiratory infection incidence in duration, but here we see that the Concurrent review on probiotics and acute respiratory infection shows some effect of the many different RCTs on the prevention of acute respiratory infection in children. But this result yielded contradictory conclusion, and some are still weak evidence and still uncertain also on the mean duration of episode of acute respiratory infection. So then we they're doing the study. So we actually did the systematic review and meta-analysis to be soon submitted on the effect of gut-mediated intervention on gut and lung immunity and pathogenicity of respiratory tract infection. An integrated systematic review, actually leading by Professor Dr. Anwar Shankar from Oxford University, our team from Department of Nutrition, Business Center, and also young scientists from our center, supported by Blackmore Institute, Australia. So the aim of the study is to assess the current knowledge on the gut-lung axis, and with specific goal of identifying potential micronutrient and prebiotic intervention that modulate the axis to strengthen immunity against respiratory tract infection in general, including perhaps COVID-19. So if you look at here, then our question is actually how the lung and gut microbiota influence each other and may impact on respiratory disease, and how this influence the gut mediated interventions such as those mentioned before, probiotics, prebiotics, and micronutrients. If you look at this concept where gut and lung are anatomically distinct, but potential anatomic communication and complex pathway involving their respective microbiota have reinforced the existence of what we call as gut-lung axis. The recently emerged concept involved host microbe as well as microbe-microbe interaction based both on localized and lung-reaching effect. And this GLA can shape immune response and interfere with the course of respiratory disease. And if we see the condition of this basis in gut microbiota, it's also seen that it's very much associated with lung disorder and also respiratory infection. These figures show that a proposed model of regulatory influence of gastrointestinal microbiota on immunological of the lung. So here we see that the role of the dendritic cell either directly from the lumen or following translocation through the M cell in the gut lymphoid tissue. So the combination of signals of microbes result in phenotypic changes in the dendritic cell and migration to the draining lymphoid node. And this DC promote the activation of various T cell subset here within the mesenteric lymph node and production of various regulatory cytokine such as EL10 or ENF gamma and EL6, and the T cell subset also then acquire immune homing molecules. So following immune challenge in the airway here, the cell activated in the gullet and also in the mesenteric lymphoid node traffic to the respiratory mucus through the chemokine receptor. So this, I think, very important pathway. And we also see that there's also a production of the bacterial metabolites like short chain fatty acid that affect the gut-lung axis, as well as also the mechanism on the production of various pro and anti-inflammatory response to the inflammation. So this actually something that we look on our study and see what the effect of the probiotics, micronutrient, and so on respiratory infection. But at the same time, those on the gut symptoms, and see what kind of biomarkers result from this pathway. So what we did, actually, we include about more than 8,000 studies. And after showing the potential duplicates and also see the all the potential, also many different types of unmatched on the outcomes. So we looking at about 7,000 articles, and this actually after showing many different outcomes, we then reported about 144 studies. So later, these 144 studies are actually classified into different outcomes. So I would like to share some of our results, although not all, which actually stimulate our discussion today. So the study characteristics, it's really surprised. The study actually comes from almost all over the world. So this is actually studies that we included, except the one which is gray. So this is mostly on the, many different, including also Indonesia and also many part of the world. Yeah, and what we see here actually main studies are actually on probiotics. Although we look at also vitamin, minerals, and the mixture, and also the other. And we also see that most of the study are human studies, about almost 80%. Besides, we also looking at on animal studies and animal vaccination study as well. Okay, so this is a first observation that we found. From 47 studies, when we look at the effect of gut-mediated intervention on the incidence of respiratory tract infection, this study actually have a couple where they have a respiratory infection as the outcome, at the same time also gut infection. So from these studies shows that the significant decrease in incidence of the respiratory tract infection by it's protective, in favor to intervention of about the odds ratio 0.7. And when we look at the stratification, like for example here on the probiotics part and also on the mineral part and also the vitamin and also the other, all actually are also significant effect except for the vitamins. So this is what actually quite promising. And then later, we look at also the average duration of the respiratory tract infection from 26 different studies. And what we found here is actually the gut-mediated intervention show a shortened average duration of arthritis eye symptoms by the standardized mean difference of 0.16. Perhaps about 1 or 1.5 days. And this actually also, we look at much more related to these probiotics rules. And when we look at again on the duration of the gut symptoms of the 15 studies reported, where we look at from the participants that experience at least one episode of gastrointestinal infection or symptoms. Yeah. So here we look at the gut-mediated intervention showed a significant decrease in incidence of gut symptoms from 0.79 odds ratio. So this is quite promising, especially when we look at from the probiotics. And then our interest is, of course, whether they actually have relationship. Those who are actually with the effect size on the gut infection, as well as the respiratory tract infection, whether the gut-mediated intervention also correlated each other. So on the meta-regression here, showed the association between the effect of gut-mediated intervention on gut and respiratory tract infection symptom with the R-square of 76%, the p-value of significant or 0.018. So this actually showed that the effect on the gastrointestinal indeed also giving the effect of the respiratory tract infection based on this meta-regression. Quite promising. So the effect, then we look at the mechanism, whether the one that I mentioned before on the concept of gut-lung axis really proved. So then we look at all the biomarkers. We classify all studies with biomarkers on immune system. First, we look at the antibody markers. So on the antibody markers, there we can look at 9 different studies where this gut intervention show significant effect on increasing antibody production during the respiratory tract infection with the overall SMD of 0.5. And here we look at one by one. Here we can look at secretory IgA, the IgA, IgG, IgM, and we look at here seems to be the one that related to the IgA or secretory IgA, the one which actually seemed to be more giving a significant effect on increasing, the production of this antibody production are much more seen on that particular antibody marker. And here in this part, we actually looking at one by one. Even in the study, like for example, if you look at Zhang here, we also look at many different biomarkers, and then we compile that together as a composite antibody markers on these 9 studies, and we show that there's a significant effect on still consistent increasing antibody production during respiratory tract infections. So by the 0.42 is also similar from previous one, a little bit lower from the 0.50 when we look at one by one. So then we look at the other markers. On the other markers, effect of gut-mediated intervention on immune cell. So we look at here various immune cell. If you look at here, for example, lymphocyte, monocyte, neutrophil, and also macrophage, and so on. Unfortunately, overall, the gut-mediated interventions show no significant effect on immune cell. So then we look at, again, on the anti and pro-inflammatory cytokine production, based on 7 studies, but very limited on anti-inflammatory cytokine. And here we found the pro-inflammatory cytokine as well as the anti-inflammatory cytokine, the effect of gut-mediated intervention are not significant. So especially the study are actually very much dominated by the probiotics. So we do not look at one by one what kind of probiotics here, although probiotics is strain specific and their effect is really strain specific, but in the general view here showing there's no significant effect on this anti and pro-inflammatory cytokine. So then I would like to make a conclusion based on our systematic review. If you look at already on our study on gut mediated related to diarrhea, especially on probiotics, show a very promising effect. So from here, when we combine together with the acute respiratory infection, the gut-mediated intervention, we would like to say that may modulate respiratory tract infection. What we can see here, significantly decreased incidence of RTI symptoms, significantly shortened average duration of RTI symptoms, a significantly decreased incidence of gut symptoms and also duration, and significantly association between respiratory tract infection and gastrointestinal tract symptom. And although we did not find the significant effect in increasing on immune cell pro-inflammatory cytokine production, but there's a significant effect in increasing antibody production during respiratory tract infection. So I would like to then, thank you. I would like to acknowledge the funding support for Blackmore Institute Australia. Last but not least, thank you for your attention. I would like, I hope that this actually will bring stimulated question and also discussion. Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Great. Thank you very much, Dr. Rina. That was a really excellent presentation, very exciting. And I think we're going to go ahead and proceed to the next presenter, and then we'll take the questions at the end as a group of questions. But that was very exciting, innovative work there, and very happy to hear that. So we're going to move on now. I think we have with us also our next presenter, Dr. Marcel Simadibarata, and he's done some very outstanding work actually in intestinal inflammation. So we're very happy to hear from Professor Simadibarata. He's a fellow of the American College of Gastroenterology. He did his doctoral degree at the University of Amsterdam. And his current position actually is a gastroenterologist and professor of gastroenterology at the Cipto Mangunkusumo Hospital here in Jakarta. So very excited to have you here with us today. Professor Marcellus, over to you, and looking forward to hearing from you. Thank you.
Thank you, Professor Anurag Shankar, as the moderator. Yes, I want to present my topic about the use of probiotics in era of pandemic COVID-19. Do I have to use the video, or I have to present directly with the PPT?
Either way, my understanding is that let's see, maybe the committee informed me that I guess we have Professor Diego's presentation, which we will show after you. If you would prefer to present live, we're happy for that.
Share my slides. Yeah?
Okay, sure. Fantastic.
Yes, so my topic is the use of probiotics in clinical practice during and post COVID-19 pandemic. And this is my outline, introduction, and etc. And as you know, that the gut microbiota and host mucosal immune system maintain intestinal homeostasis and induce systemic protective responses. And we know that from the studies showed that the probiotics regulate the functions of systemic and mucosal immune cells, and also the intestinal epithelial cells. And we have known from the research that probiotics have many benefits in COVID-19 infection. This is the adaptive immunity consists of humoral immunity and cell-mediated immunity. And our body, the humoral immunity, use the antibody to increase the immunity of the body. And from the cell-mediated immunity, it is use the cell, like the B cell and T cell, and then the cellular immune system. And the effector sites of the intestine are the mucosal epithelium and underlying laminate propria. And there are many different immune cells, including activated T cells, plasma cells, mast cells, dendritic cells, and macrophages. And the T and B cells has a role in adaptive immune response, maintaining the epithelial barrier and suppress responses to harmless microbes, promotes immune homeostasis. And we know that the gut microbiota is one of the largest interfaces between 250 to 400 meters square. And also the number of microorganisms exceed to 10, 14, and also 60 or 70% of immunity cells is in the gut microbiota. And all diseases begins in the gut, and this is proposed by Apparatus a long time ago. And we know that there is a correlation between the gut microbiota and the intestinal cell, intestinal organ. The complex microbiological system responsible for the host health with the cooperation of mucosal barrier and local immune system. And this, we know that there is correlation between the bacterial microbes, the microbiological organism in the gut, and the gut system. The microbial organism can induce modulins and make a modulation of certain biochemical and then there is a sensing interfaces, interrelation between the microorganism and also the gut. And also in the gut, the microbiota has correlation with the immune modulation through the increasing the T helper 17, increasing the also the cytokines, also the interleukin 6 and interleukin 12, and also the other interleukin 10. And there is many effect of the microbiota to the cells, the immune system in the body. And what is probiotics? Probiotics is live microorganism which, when administered in adequate amounts, confer a health benefit on the host. And we have a lot of probiotics available in the market, like Lactobacillus species, Cocci gram-positive, Bacillus gram-negative, and Bacillus gram-positive, Bifidobacterium, and yeast. Yeah. And this is in the market. We have probiotics in the yogurt. If you go to the market, in Indonesia and other world, we can eat yogurt, so we can increase our microorganism and our probiotics. And this is the mechanism of probiotics in increasing the immune system by increasing the natural protection in the large intestine and stimulate the immune system, increase the antibody production, and increase the other system. And this is probiotics. So the commensal bacteria or probiotics can increase the helper 17 and also increase the interleukin 20, also increase the alveolar macrophage ROS, and also inhibit the opportunistic pathogen in the gut. And a lot of studies like in vitro studies and in vivo studies and also the human clinical studies show there is a relation between the probiotics and the TLR3, and the in vitro study showed that they decreased TLR3, TLR7, and increased the MX1, RX1, and increased the interferon alpha, interferon beta, increased the interleukin 10, and decreased the interferon VA replication. And in mouse in vivo studies showed that there is a decrease of symptom scores, decrease of viral load, and increase the interferon gamma, interleukin 12, and also increase the type 1 interferon response, and increase the natural killer cell activity, and increase the antibody response. And human, there is a relation between the probiotics and the decrease of incidence of symptomatic illness, and also the decrease of the duration of illness, and also related to symptom severity and a sense of from school or daycare. And the modulation of inflammation by probiotics is we can conclude that there is a decrease in C-reactive protein levels, decrease of tumor necrosis factor alpha levels, increase interleukin 6 and interleukin 10, and increase the level of pro-inflammatory cytokines like interleukin 17, tumor necrosis factor, and increase transforming growth factor beta 1. And as we have already heard from Dr. Rina Agustina, there is a relation between the gut and the lung. So there is gut and lung axis. So the probiotics can influence the functions of the macrophage and dendritic cells, and influence the differentiation activities of T cells, enhance the cellular metabolism, and regulate the gene suppression of promote the beta cells. Yeah. So because of the lung gut axis, so there will be increase of the short-chain fatty acid in the gut, and also increase of phagocytosis by the macrophages and stimulation of the immune cells, and then it will clear the pathogen by the bacteria in the gut or in the lung. And how is about the relation between the probiotic and the COVID? Yeah, the COVID can delay or suppress type 1 interferon response, and also viral replication triggers hyperinflammatory conditions, and influx of activated neutrophils and inflammatory monocyte macrophages, and also induce the T helper 1 and T helper 17 in specific produce. Yeah? So the probiotics will inhibit this effect caused by the COVID-19 infection. So in many studies showed the infection of COVID-19, there will be an imbalance in the intestinal. So the intestinal microecological balance is broken, and then manifesting by a significant reduction of intestinal probiotics such as the lactobacillus and bifidobacterium. So that's why it is very important to restore the imbalance or the dysbiosis in COVID-19. So this is this cartoon showed that there is effect of the COVID-19 infection to the gut microbiota. So the COVID-19 also make a dysbiosis and make imbalance between the normal microflora and the inflammatory cytokines response. So also this cartoon shows that the infection of the COVID-19 can alter the affect the ACE2 receptors and also cause viral docking and replication, and then alter the gut-lung axis and cause the dysbiosis. And there's after that there will be bacterial translocation, secondary bacterial infection can induce the immune dysregulation, hyperinflammation, and also can cause the multi-organ dysfunction or death. And then, there is a lot of theory that the probiotics can alter the dysbiosis. So this probiotics can increase the lactic acid production, can decrease the intestinal pH, and increase absorption of vitamin D, and decrease serum concentration of vitamin D. Also can enhance the vitamin D receptor expression and signaling, and also increase the number of Paneth cells, and can enhance production and expression of antimicrobial peptides, and then it will cause anti-inflammation, can increase the antioxidant, and increase the antimicrobial effect in the body. So many studies showed that there was alteration or imbalance in the microbiological system in the gut. Many studies showed in COVID-19 there is abundance, there is increase of abundance of pathogens in the gut, and also the imbalance, the normal gut flora is broken in the gut. So there are a lot of studies, but we need maybe a lot of more studies about the dysbiosis in COVID-19 infection. But we have these 5 studies that showed that there is a role of the COVID-19 infection can cause the dysbiosis. So Kenzo et al. Proposed special food for to improve the COVID-19 infection, including the functional food, prebiotics and probiotics, and postbiotics and symbiotics to recover this dysbiosis in COVID-19 patients. But the study is still ongoing, and they conclude also from Singh et al. Probiotic has a potential immunomodulator effect in COVID-19 infection management. So they can normalize the immune system, and also can normalize the dysbiosis, and then can recover the imbalance in the gut. So this is a study by Klemat and showed that the probiotics produce the bioactive peptides with the capability to inhibit the enzymes by blocking the active sites. And prebiotics may also have an excellent potential effect against COVID-19 by enhancing probiotic growth and survivability. And several registered trials that aim to investigate the efficacy of probiotics in treating COVID-19 patients are ongoing. So they conclude that probiotics combination between probiotics and prebiotics is very beneficial for the COVID-19 infection. So this is study in Wuhan, a retrospective study from China. They make a study on patients with COVID-19 infection in 2020 from February 3rd to the February 20th, retrospectively. Yeah, and the result, 75.65% were treated with probiotics, survived in the hospital discharge with a median length of stay 32 days, and the mean virus clearance time is 23 days. But the length of study, and this is longer than the patient without probiotics, but maybe there is something wrong with the study. Maybe we have to make a prospective study because this is retrospective. And also there is no difference between the interleukin-6 before and after the treatment with the probiotics. But from this study showed that there is a decrease of secondary infection, and also the well-being of the patient is better in patient with probiotics. Okay? And this also the length of stay of the patient and with the probiotic is longer than patient without probiotics. Okay, this is the study. And conclusion, the probiotics could be effective strategy for the treatment of COVID-19 to reduce the secondary infection and moderated the level of immunity. And this is COVID-19 also can affect the interleukin 18, MCP1, and IP2 and IP, and then cause the increase of the interleukin. The probiotics can increase the interleukin 17 infection, and also can decrease the hyperinflammation effect in COVID-19 infection. This is a study about probiotics in many situations with viral infection, like as already been told by Dr. Rina Agustina, that lactobacillus or maybe the other probiotics have a good effect in a viral infection. Like here in infection of pneumovirus or RSV, and also the rhinopharyngitis influenza, the lactobacillus species can treat the patient with the viral infection and decrease the length of the infection. And also the bifidobacterium can improve the upper respiratory tract infection, and the Lactobacillus plantarum and other Lactobacillus subtilis also have the good response in other infection like coronavirus gastroenteritis infection. So this is a study about the probiotics and upper respiratory tract infection. Showed the study there is a meta-analysis showed that there is improvement if the patient has got the probiotics if compared to placebo. Also in the adult and the children, the effect is better than if you use a placebo. Also, for the treatment of COVID-19 effect, we can also treat the patient with other gastroenteritis diseases like acute diarrhea, or we have a patient with Helicobacter pylori infection. We can treat also the patient with constipation. We have treat the irritable bowel syndrome, inflammatory bowel disease, and also cancer prevention. So because we have a lot of patients in GI besides the COVID-19 infection, so we can treat this patient with the probiotics in the era pandemic. This is the WGO guideline showed that the probiotic has a good effect in antibiotic acid diarrhea. We can use the Lactobacillus acidophilus, rhamnosus, rotary for the patient with this antibiotic. And also, yes, this is irritable bowel syndrome. It's also the same. We have the meta-analysis showed that the improvement. Okay, this meta-analysis. Also the constipation, there's improvement, functional constipation. This in conclusion, probiotics have a role in boosting immunity, and the probiotics can be used to prevent and treat many diseases, including COVID-19 infection and clinical practice during and post COVID-19 pandemic. Thank you very much for the attention. We give back the time to moderator, Professor Anuradh Shankar. Thank you very much.
Yeah, thank you very much, Dr. Marcellus. Very interesting talk, really covered a wide range, and you saved an additional 2 minutes. Very, very impressive. Okay, so we're going to move on to the next talk, Dr. Diego Peroni, and they have found the recording. So we'll see this recording from Dr. Diego. And Dr. Diego completed his doctoral degree from University of Southampton. And he has completed his training as a doctor at the University of Verona. He's currently the professor of pediatrics at the University of Pisa. And actually, very interesting, he's a director of the residency school of pediatrics at the University of Pisa. And I was looking at his publications, a very interesting, outstanding publication record across probiotics and allergy, gut allergies. And so it's a very big honor to have you with us here today, Dr. Diego, and looking forward to see the recording and having some good discussion with you thereafter. So yeah, the committee, please launch the nice recording.
Dear colleagues, I would like first of all to thank the organizer for the very kind invitation. It's an honor for me to be with you and to talk about the practice on probiotic use during the pandemic. First of all, I would like to underline how much the microbiota is important in our life. We know that microbiota could give indication from the gut to the lung and other organs which are particularly sensitive. So in the defense mechanism, I believe that the gut-lung axis is quite crucial and absolutely important. We have to reinforce our microbiota since we know that diseases such as the viral infections are so important in affecting the health of the subject and of the children. And we know that prescription of drugs and antibiotics in particular could have a negative effect. Therefore, to reinforce the microbiota is absolutely important, giving a reinforcing to the immunity of the local and systemic effect. So we know that probiotics from this side are quite crucial, since probiotics can act as adjuvants during the prevention and during therapy, even during vaccination strategy. Why? Because they have a lot of effect in modulating the microbiome itself and the immunity of the subject. This is very important since we know that they are releasing a lot of compounds which are able to modify the microbiota. And at the other time, they are affecting the immune system of the infant, of the newborn, and of the child. And by several factors, as is demonstrated in this slide. But coming to the practices on the use of probiotics in the international practices, we have indications that are quite old, as this one, but quite clear, since some of probiotics, some strains of probiotics are effective in some condition. And we have to see that acute gastroenteritis, antibiotic-associated diarrhea, allergy, enterocolitis, and other infection and condition are affected by the probiotics. Coming to more recent time, we have indication for and a recommendation from the Asian Pacific region as this one, which are quite clear in my opinion. So the use of probiotics should be considered, and we have again the strains which are really effective in acute gastroenteritis, in antibiotic-induced diarrhea, in other situations which are quite clear. And the more recent paper probably is this one from the S1 group, where the guidelines are again quite clear. The demonstration that the probiotics are effective is still controversial in some times, because we require even more papers on effective, since as the authors underline, they couldn't identify two RCTs of a high quality for any strain. And this, of course, this contributes to the controversial point. But as we can see, there are weak recommendations which for acute gastroenteritis Bacillus reuteri DSM 17938 that could have an effective. So this could be a point that could be of effective in the pathology. So they conclude that the use of probiotics with this documented efficacy may be considered in the management of acute gastroenteritis. Again, we start now with the probiotics and the role of strain specificity. That is in prevention and treatment. So we have indications that are quite clear that the probiotic could respect some indication, a sort of checklist which should be indicated. Probiotic strain must be sufficiently characterized, safe, supported by clinical trial results, and the like. And these points are absolutely clear and so important when we talk about the use of a particular probiotics. So we have to consider, I told before, that the probiotics should be alive. And this is a fundamental requirement for the probiotics itself. And the other point is the strain specificity. For example, coming to Lactobacillus reuteri, there are several strains, but we have to look at the results in the literature. Since talking about reuteri, the strain DSM 17938 has a high variety and possibility to produce metabolites which are really effective than disease in terms of prevention or in treatment. And we have at the bottom of the slide indication from the literature that are quite clear on this effect. And so we have to consider that probiotics are able, certain strains of probiotics are able to interact with the microbiome, with the pathogens, with the immune system by producing messages, molecules, which are able to give indication to all the microbiome or the immune system. And the reuteri is able to produce these antimicrobial molecules to inhibit the colonization of pathogenic microbes, to give indication producing this reduction of pro-inflammatory cytokines and strengthen the intestinal barrier, which is absolutely relevant, absolutely important. By producing, as example, some vesicles which are able then to give these messages in the microbiome in the gut, but probably reaching also the apparatus and the organs which are far away from the gut. And this probably is the way which, by which the gut-lung axis is working. So which are the current probiotic clinical evidences during pandemic that we can use in the prevention? The prevention of viral diseases, we have indication, this a pioneeristic paper by Wiesmann, where administering reuteri was, the authors were able to demonstrate an effect of less episodes of fever, less episodes of diarrhea, less doctor visit. This is the point that we require in terms of prevention by an active treatment as with the probiotics. And I am delighted to be in this session with Dr. Agustina, because this paper is absolutely clear to me, and is a paper that I mention every time. And again, here, the reduction using administration of reuteri of diarrhea, episodes of diarrhea was absolutely relevant, more than giving lower calcium or regular calcium or other probiotics. So the effect was really specific of that strain. And we have indication from a paper of my friend Pedro Gutierrez Castrillon from giving in this child were preschoolers or Reuteri DSM 19738 or placebo for 3 months. And then in the follow-up of other 3 months, there were less episodes of diarrhea. It was absolutely significant in the treated group, less episodes of respiratory infection, again, during the treatment of the first 3 months, but even in the following 3 months of follow-up, and again, less fever and the school absenteeism. And there is a particular point, because this intervention was really cost-saving for the community. And this is a point that we have to consider when we need to produce some indication in terms of prevention or treatment, even using probiotics. There is a paper now that is just published by the same group, where an association that you can see again of the Reuteri DSM 17938 with another strain of Reuteri in a small group of patients, but looking at the treatment in this case of viral infection, of upper infection. And you can see again that the treatment by the association of the 2 strains of Lactobacillus reuteri were able to reduce the days with symptoms, to reduce the sore throat severity. And this is a very interesting point, because before we were looking at the prevention that is absolutely important for the pediatrician, but even the cure, the treatment of the episodes is absolutely important. And so the timing of resolution in yellow, the association of the 2 strains of fever. And this is a major point, since we need this effective treatment when we talk about infection. So there is another point that is crucial in my point, is that we can add some other factor, adjuvant factor to the probiotics, and vitamin D is so important. We have an indication that vitamin D is relevant in terms of prevention of respiratory infection. And we have a lot of data that supplementation could be effective, but is particularly effective when the administration of vitamin D is performed daily and not by bolus monthly. And the effect was particularly greater in the subject with have a particularly lower level of vitamin D at the baseline. So these are crucial points, and we have again, in my opinion, indication that supplementation or combination of Reuteri DSM 17938 and vitamin D may act in a synergistic way, because they are both working on producing antimicrobial molecules. They are effective in a positive way, the innate and adaptive immune system, and they are enforcing the strength of the tight junction at the gut level, but even in the mucosa. So this is very important. And this another paper on asthma, on rhinitis asthma, but is particularly interesting because the association of vitamin D plus Reuteri was able in asthmatic patient to reduce significantly respect to the placebo-treated group the level of nitric oxide, exhaled nitric oxide, which is a marker of bronchial inflammation. In other terms, the combination could really be effective in reduced inflammatory response of the system to allergens in this case, but I believe even to infection. There is a new perspective of the use of probiotic during pandemic. I think so, because we have indication that the severity of viral respiratory tract infection, a coronavirus is among them, is particularly high if there is a status of imbalance at the level of microbiome and at the level of immune system response. We know that in COVID-19 patient, the gut microbiota has a deep alteration, particularly during the time of hospitalization, because it's particularly rich of opportunistic pathogen. There is a depletion of beneficial commensals, and all this system, this dysbiosis is working probably, giving a negative profile to the COVID-19 disease. And again, this patient has reduced bacteria diversity. They have a higher relative abundance of opportunistic pathogens and a lower relative abundance of beneficial symbionts. And this is particularly relevant because if we consider the action of probiotics, we can consider that the right strains of probiotics could give some effect at different point of the viral infection, when the virus is reaching the mucosa, when there is a replication of the virus, and when we need from the system, particularly from the microbiota, the right indication, the right metabolites, the right messages that can reach the organs, such as the lungs, which are involved particularly in the viral infection. So in conclusion, this is my last slide. Probiotics are not all the same. And so we have to consider the specificity of effect. We have to consider the what are the indications by the guidelines, the international and national guidelines. We have to consider the effect and the results of the trial that have been performed with the probiotic. Considering that not all the probiotics are the same in terms of the efficacy and in terms of the dose that is required to be effective. Because when we consider that the strain is effective, there are indications that are quite precise that that dosage is really effective. And not that the greater amount of probiotics is more effective. When we consider the efficacy and the effect of the probiotics, we have to consider the widespread effects, but we have to consider particularly the more specific, the rare strain-specific effects, which are particularly important for the prevention and for the treatment use. So in our armamentarium, probiotics, particularly some strains with specific effects, are particularly relevant to give a real effect. I would like to thank you very much again, and please, I am ready for your question to give the answer. Thank you very much for the kind invitation again.
Great. Yeah, fantastic. Thank you so much, Dr. Diego. It's very nice presentation. Particularly highlighting the heterogeneity in the probiotics and our need to really identify very specific probiotics for very specific outcomes. So thank you for highlighting that very complex topic, condensed down very effectively into a short period of time. So we do have some questions that have come in. Of course, we're running behind schedule, but we have some very nice questions, I think, that have been raised. So let me just first mention, there's a very nice question to Dr. Rina Augustina specifically, but it'd be good to hear from others as well. Is there any recommendation regarding probiotic requirement for daily intake? And the other one is that, you know, particularly in the context of how to get the best functioning probiotics, and the concern raised about, you know, the yogurt on the market is tends to have a high sugar content. So basically, Dr. Rina, the question is, you know, what do you feel is the appropriate recommendation at this point, given the evidence regarding probiotics? So I think that's a key question there. And for Dr. Marcel, let me raise this question specifically for you that actually has come in. Is there any research specifically in Indonesia, either intervention trials or other sort of observational studies, specifically looking at the impact of probiotics on COVID disease? And if there are, you know, what would your recommendations be at this point to the government? And then I would actually like to raise a question actually for Dr. Diego specifically as well. You know, this issue of how is the gut-lung axis really interacting? So in several of these slides that were presented across all three of you, there's this discussion about the short chain fatty acids. That seems to be a key thing people are looking at. But you raised, Dr. Diego, something else that was extremely interesting, which these vesicles and these microvesicles, and maybe what the role of those is in this gut-lung axis. And could you also talk about the relative contribution of perhaps other ways that this gut-lung axis is interacting? So these are these three questions, I think, for each of you. Dr. Augustina, would you like to take your question first?
Thank you very much, Dr. Anurag Shankar. Very great question, very important as well. As mentioned by Professor Diego, and also based on various studies, we know that probiotics is really strain specific. So it means that when we look at the dosage or the intended use of what kind of outcome is all very strain specific. So, what I can mention that the most important here is the best clinical evidence is on the prevention and treatment of acute diarrhea, although it's not part of the protocol of the current WHO guidelines. The WHO giving the kind of nice guidelines actually in 2001, also following the definition of probiotics, but there's no such recommendation specifically from WHO, but we can from different society or professional organization, they are very much some of the potential use on the treatment and prevention of diarrhea, as well as on the antibiotic-associated diarrhea for children and adults. So those two are actually the most convincing evidence. And now I think with the current use and also the systematic review that we perform and also many different evidence, I think we should very sure that these probiotics may actually very much also in conjunction with the other comorbidity of diarrhea, which is respiratory infection. So, but I think it still need to be more studied, of course, on this part. Yeah. And in relation to the strain specific, people are actually also sometimes confused between probiotics and fermented product. So this has to be also very much need to be more knowledge about this one. So fermented product, with the starter. It depends on the kind of starter. Some of that on the yogurt, they may actually accelerate the lactose intolerance. So there's actually also some information from the EFSA validation or, for example, evaluation, but not all actually also act the same. Yeah, so fermented products are reused for history as well. Yeah, but then we have to look at more on how they actually act on the digestibility of the lactose. Very much on that. So if they want to add yogurt plus with the probiotics, then they can actually use that in relation to what kind of outcomes. Yeah, so I think yogurt now is very much sugar a lot, but I think which the one which actually low sugar. Yeah, thank you. I think that's all for now, Dr. Anurag. I hope it actually answered the question. I think Professor Diego and Professor Marcel can also give some more information on this one. Thank you.
Yes, yeah, thank you so much, Dr. Rina. That was helpful. Over to you, Dr. Marcel. Yeah, please, there was a specific question for you, and if you'd like to give a comment on the question to Dr. Agustina, certainly please feel free. Go ahead.
Thank you, Professor Shankar. About the question, I agree with that's already mentioned by Dr. Rina Agustina and also Dr. Diego, Professor Diego Peroni. So I agree. So we have a lot of studies and adults and also showed many benefits of the probiotics. And about the questions about the study of probiotics and COVID, what I know that until now there is no studies in Indonesia about the effect of probiotics, the role of probiotics in normalizing the gut flora in COVID-19 infection patients. But we are now our plan is to do the study about giving the probiotics and COVID-19 infection to normalize this dysbiosis. Yeah. So and in 2020 and 2021, we just got shocked because of the effect of the pandemic COVID-19 of the a lot of death. So that maybe in this year we will do study about how is the microflora in COVID-19 infection, maybe in conjunction and cooperation with Dr. Rina and Yani, and then the others. We do this study. Yeah. Maybe the one of the pharmacy like Interbat wants to sponsor our study what the effect of probiotic in COVID-19. Maybe we make a cooperation with our FKUI and also with Interbat. So maybe we will do it in this year or maybe finish next year, maybe. Yeah. Thank you, Professor Shankar. Yes.
Okay, thank you, Dr. Marcel. Very interesting. Over to you, Dr. Diego. And actually, another question has come in for you while they were talking, which was this issue. If you could discuss briefly about the potential use of probiotics in non-communicable disease also. If you could give a comment on that. And so then the other one is with respect to vaccination, you know, the priority of this, how to potentiate vaccination, and maybe any recommendations you might have based on your review, what you think good candidates would be from a probiotic standpoint for potentiation of the vaccine response and the duration of protective immunity. Yeah, so over to you. Thank you.
Thank you so much, Professor Shankar, for the questions. They are so interesting, really. And I can comment that the COVID infection pandemic was an opportunity, is an opportunity now to better understand the mechanism of action of different things such as probiotics, vitamin D, or nutraceuticals. And it was a surprise for me to study for this revision of the literature that I have produced for science, that there are a lot of data regarding animal model. In other words, for the animals, from a veterinary point of view, probiotics are quite often used as adjuvant for vaccination. In human, we have really few data on this, but I think that we have to consider the mechanisms again. So it's very, very important to focalize on interaction between some strains of probiotics and immune system. Immune system of the infants, of course, but of the subject. So there is a study which is going on regarding administration as adjuvant factor of a combination of reuteri plus vitamin D in efficacy of the COVID-19 vaccination. Mm-hmm. And this is a very crucial point. And the mechanism of action, again, are quite interesting, but we need, of course, data from clinical human studies. And this is the crucial for every point. As Dr. Rina has shown, when we make then meta-analysis and the revision, the data are quite often not so clear and not so useful. But again, since we need more data from the same strains. I mean, you have shown in my slide that the SPN group was not able to find at least 2 or 3 studies with the same strain. This is a major problem with when we talk about probiotics, the heterogeneity of the probiotic. In Italy, we have on the market, just to say, 600 products containing probiotics. And so you can imagine which is the scientific approach to this fact. That is terrible for us just to demonstrate. And the other point that is quite fascinating is are the mechanisms by which the probiotics are communicating with the immune system and probably with the lungs and with the other organs, such as the brain. And vesicles are probably one of the methods. But we know that short acid fatty acids are again so important. But again, we need demonstration. We need to pull our efforts as scientists on this point. So we have in the next future we need more data, of course. I don't know if I have answered to all the points, but I have given just my point.
That was very, very helpful. I'd like you to comment briefly on the use of probiotics for non-communicable diseases, but I want to actually first give a little bit of time to Dr. Rina, because I think Dr. Rina has an ongoing randomized controlled trial of probiotics in pregnancy. It's still a blinded study, but Dr. Rina, maybe if you could just articulate what kind of outcomes you're hoping to look at with that in conjunction with COVID-19. I know your study started before COVID-19, but there may be some very useful insights there in that. And could you give a brief comment about that?
Yes. Okay. Thank you very much, Dr. Anu. Yes, we are now doing the randomized trial of 300 pregnant women. 50% are actually before pandemic and 50% after pandemic. So these 300 others, we follow up for now. It's already 3 years. The study is 3 years, so we follow up until the children born from 4 months and 6 months. And then we also get now more funding from government to follow up until 2 years old. So the outcomes of this study, we almost finalized actually the outcome by end of this December. We look at more on the gut-brain axis by seeing from the fetal brain. So we started on assessing the MRI from the abdominal MRI of the mother and looking and quantifying the all the brain structure from the MRI. So now we completed about 200 mothers and hope this actually can also be related to the other outcomes that we follow up on 4 months and 6 months on the cognitive function. And we also looking at the eye tracking, so they're visual, but also on the BERA, so on the audiovisual, so audio and the visual. So the all these together will also can see whether there's a correlation with the MRI assessment with all this cognitive function actually induced by the intervention on probiotics plus with omega-3 fatty acid.
Okay, very interesting. Extremely helpful. I'm going to give just a few seconds back for you, Dr. Diego. Any final comments on potential for probiotics for non-communicable diseases?
Thank you for the question, Professor Shankar. This is a very wide argument. And so I hope that you will invite me for the next year regarding this topic.
We'll do.
And I am very pleased for the question, of course. And there are some indication again, but the argument is absolutely controversial. But we know that non-communicable disease are, particularly in the Western countries, a real problem. I don't know in Indonesia, but I am sure they will start to be a relevant problem even there. And therefore, we have some indication again regarding mechanisms, regarding some topics, and particularly for allergic diseases, we have indication that some strains are working probably, but we need even more study. And the other point is the strain specificity in this case is particularly relevant, and the timing is particularly relevant of administration. So the administration, if you want to really prevent this non-communicable disease, the prevention should start very early during pregnancy and then continue in the early phases of life of the infant. So I'm ready for the next year.
Great. Okay, fantastic. So I'd like to thank all the speakers. Very nice presentations, very nice insights. And I think this is extremely important, topic. I think the key is if we can launch some very nice research initiatives here in Indonesia around this, very strong potential. All the evidence that you all presented, very likely to be extremely important as part of the solution for the pandemic and many, many other things also. So with that, I would like to bring this session to a close, and let me give it back to our organizers, I think Dr. Sukma and others. So thank you again all, and have a very good evening and good morning or good afternoon wherever you are in the world.